Directorates, I warmly welcome you to the high-level forum on actions for improved governance and ethical practices in the health and pharmaceutical sector. This forum serves as a multi-stakeholder platform bringing together academia, civil society, policymakers, and industry leaders to chart a collective pathway toward ethical, transparent, and patient-centered health system. We are honored to have such a distinguished group with us today. I would like to start with the name of Almighty Allah. For this, I would like to call Mr. Usman.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم إذا جاء نصر الله من فتح ورأيت الناس يدخلون في دين الله أفواجا فسبح بحمد ربك فاستغفر إنه كان توابا صدق الله العظيم.
Jazakallah. To formally open today's proceeding, I would like to invite Justice Zia Parvez, former judge of the Supreme Court of Pakistan and chairman of Transparency International Pakistan, with decades of judicial experience and leadership in governance and anti-corruption reforms. Justice Parvez will deliver the welcome remarks. Justice Parvez, sir, please.
Bismillah ar-Rahman ar-Rahim. Distinguished guests and esteemed participants, Assalamu alaikum. On behalf of Transparency International and Patients Not Profit, it is my privilege today to welcome you all at this high-level forum for actions for improved health governance and ethical practices in Pakistan in the health and pharmaceutical sector. The healthcare system of Pakistan confronts multiple governance challenges. Some of these challenges include weak regulatory enforcement allowing substandard drugs to be marketed and they circulate, resources and capacity constraints in the enforcement mechanism, and oversight of bodies result in persistence of unethical practices, including patients' rights and safety. At the same time, the silver lining is that there is also a growing recognition and calls for healthcare governance reforms for Pakistan to achieve World Health Organization's maturity level 3 regulatory status. However, it's important that any attempt at reforming to health, medical and pharmaceutical standards may not be a state-led process alone. It needs to include the say and voice of the professionals, healthcare experts and other concerned stakeholders. It is with this objective that we are here today with the active support to TI Pakistan by the Patients Not Profit and have convened this forum to foster open, solution-oriented dialogue amongst policymakers, regulators, healthcare professionals, industry leaders, civil society, and governance experts so as to have the entire spectrum of all concerned on board. Together, we aim to shape a practical roadmap to reform that will restore public trust, improve healthcare delivery, and ensure that ethical standards are the foundation of our health system. Through the draft recommendations, we have highlighted some key priorities and hope to co-develop it further today, giving the final touches with your expert knowledge and experience. First and foremost, there is a need to strengthen professional standards and capacity through mandatory continuing medical education, the regular training for pharmaceutical representatives. Equally important is the establishment of fair complaint procedures, disclosure of data of pharmaceutical companies, and stronger whistleblowing protections. Secondly, we must reinforce regulation and accountability. Appointments should be merit-based. There is a need for urgent investment in technical expertise to ensure effective enforcement. It also requires public reporting of regulatory actions, pharmaceutical marketing practices, and enactment for the registration and for the licensing of nutraceuticals, which are a broad-based market, and it is not properly regulated at present. It is a collective responsibility for all of us to combine our efforts to strengthen healthcare governance in Pakistan. I hope today we will have achieved the blueprint for the future policy ahead to shape the recommendations through this forum to take these with the government and other concerned stakeholders for their implementation and effective enforcement. With that, I thank you.
Thank you, Justice Pervez, for setting the tone for today's dialogue and reaffirming the importance of integrity in the health sector. May I now invite Ms. Nina, Research Fellow at the London School of Hygiene and Tropical Medicine, to take the floor for some housekeeping announcements.
Distinguished participants, colleagues, and friends, I promise I will keep this very short so we can continue with our journey for today. So as you might know, our event today is co-organized by Transparency International Pakistan and Patients Not Profits, which is an initiative that was started by researchers at the London School of Hygiene and Tropical Medicine and researchers at the Aga Khan University in Karachi. I'm thrilled to be here today and to be co-organizing this event. It's great to be here as well with Raima Mahmood, the Master of Ceremonies for today. So As you know, we're looking at a high-level forum on health, on actions for improved governance and ethical practice. We look forward to having an open, solution-oriented dialogue with you all, and through these sessions to come to co-develop recommendations that we can take forward into a roadmap that will bring us to a more ethical healthcare system in Pakistan overall. Before we enter into our next sessions, I just have some brief housekeeping rules to maximize our time together today. So just to remind you, this event is on the record and will be live streamed, so remarks that you may give might be used for press releases and other media outputs. This is also a gentle reminder to please silence your phones to maximize our participation for today. Your agendas are in your meeting pack, which you can refer to throughout the session. And let me ensure that there will be multiple opportunities for audience input today, which will be clearly indicated by our Master of Ceremonies and our moderators. I will be keeping time for today's session, so moderators may see me hold up cards when there is 10, 5, and 2 minutes left in each session. And just a kind and gentle reminder, if you can either make remarks in English or in Urdu, both are absolutely accepted. Without further ado, it gives me great...
Bismillahirrahmanirrahim. Distinguished policymakers, healthcare professionals, Dr. Shahzad Sahab and all representatives from the health partners, Assalamu alaikum, very good morning. In fact, it's a great privilege and honor for me to start the discussion regarding the high-level forum on health actions for improved governance and ethical practice. In fact, credit goes to the Transparency International and other partners for always raising the flag when we talked about the ethics, and they always being considered as a whistleblower organizations for the overall governance structure. So if we see that how government works, by and large, for LMICs, it's always a very problem how to proceed for the governance. By and large, United Nations Sustainable Development Goal, SDGs, are the guiding principles for every government specifically and Pakistan in general as well, by which they draw their principles for further years. So there are 17 SDGs which covers health, education, infrastructure, gender equity, climate change, and so on and on. But when we see SDG 3, it specifically talks about good health and well-being. So SDG 3, good health and well-being, every government is responsible for provision of good health for its people. Again, it's always very difficult for any LMIC to provide all these facilities in isolation, responsible for supervising all the healthcare delivery system. And in both scenarios, whether it's a council, whether it's the regulatory authority or healthcare commissions, the basic purpose of the government was to establish these organizations so that they can work something different from the routine government bureaucratic culture. So that is the basic concept of establishing all these autonomous bodies or councils or healthcare commissions as well. So by and large, these regulatory authorities, councils and healthcare commissions are the supervising bodies or regulatory bodies by which they can act. So they have basic three focus in all their performance. One, service delivery to the people, whether it's a common public or if it is a council or regulatory authority, then those organizations to whom they are regulating. Second one, confidence by the government, because government wants that these all organizations should work optimally for the service delivery with some international standards. And third one is very important, that is the provision of all the resources and service delivery with transparency, accountability and ethics. So that is very important from the governance point of view, and what I believe that today's session and today's dialogue is of integral importance when we talk about transparency, accountability and ethics. So let's talk about various systems, because when being the National Regulatory Authority, Drug Regulatory Authority, we are responsible for the provision of safe, effective and quality therapeutic goods in the country. So by and large, if we see that if we have three parameters for our decision making, safety, efficacy and quality, so by and large we see that there is no mention of any ethics in this, but ethics is built in each and every component, each and every regulatory activity. When we talk about the assessment, when we talk about the compliance, so ethics is inbuilt. So it is on the part of us. At the same time, when we see for the healthcare commissions, when we see for the governance, and when we see something from other side or the healthcare industry, so they have two components very important. One is the healthcare delivery, another one is the compliance to the all the ethical principles. So it's always very important that we talk about the ethical consideration, and today I'm very happy that we have colleagues from the research as well, because research is that very body where ethics is being considered one of the very integral component when we will grant approval. But if we see that how transparency works, it is a basically whistleblower which usually highlights various problems, various bottlenecks, various gaps, and due to which, but I believe that in our organization, we have done a lot of regulatory reforms, and so it is being done by the other organization as well. And today, in today's session, what we have seen that a lot of discussion will be done, where we will discuss all the regulatory reforms, we will discuss how transparency can be inbuilt in our procedures, because if we will do all the processes which have ethics and transparency inbuilt, then we can have a good result. So thank you very much, all the colleagues, and I believe that after all this panel discussion, we will be able to have one consensus document which will be shared by the all organization and National Health Services for future interactions. So thank you very much.
Thank you very much, Dr. Obedullah, for highlighting the regulatory priorities that frame today's discussion, particularly the emphasizes on patient safety and systematic accountability. Our next session presents draft policy recommendations developed through collaborative research and consultation. We hope that today's dialogue will help us further co-develop these recommendations. I invite Professor Mishal Khan, Professor in Global Public Health at the London School of Hygiene and Tropical Medicine, and Mr. Kashif Ali, Executive Director of Transparency International Pakistan, to present the key recommendations.
Assalamu alaikum all. First of all, thank you so much for gathering here today. Half of the battle, I would say, is having the right people in the room, and we're really, really pleased to be starting with all of you here. As the organizers have mentioned, this is an opportunity for us to discuss, to disagree, to agree, and hopefully also take responsibility, maybe one step in each of our spheres, to be able to move forward on this really important issue. So by way of a brief introduction, as Raima mentioned, I'm a professor of global public health at the London School of Hygiene and Tropical Medicine, and I've been working on health policy and system strengthening in Pakistan for about 15 years now, and sort of through work on infectious disease control, this issue of use of medicines came up, and through that, the idea of why, despite efforts to improve knowledge of healthcare providers, we were still seeing a lot of overuse of medicines, and digging deeper into that is what led to this body of work, which is on the incentives behind overprescription of drugs and medicines. So here, what we will be talking about. I don't know if I skipped a slide. Yeah. So, the ethics or the unethical practices, we say it's sort of like an open secret, but they really, really are rampant. And sorry, the slide, well, I'll speak over it, but the work was that we did actually showed that so this was using actors posing as sales representatives from a pharmaceutical company, and what they found was really shocking. 40% of doctors in Karachi took a bribe, as I think that's what the policymakers would also agree it was, from sales representatives for prescribing medicines from a company that was fictitious. So what that meant is that without having any knowledge of the quality of the medicines, the history of the company, just on the basis of the financial incentive being offered, doctors were willing to make a deal and prescribe the medicines to patients. So this was a hard evidence that's led to a lot of advocacy, a lot of discussion, and a lot of people coming forward to want to address the issue. Now, like I mentioned, this is not just an issue of pharmaceutical companies and doctors. We know it happens with laboratories. We know it happens with doctors also referring for specialist care when it's not needed. But instead of patient care being at the heart, there's these concerns about profit making really taking over clinical decision making. And this is just a snapshot of some of the local press coverage on this issue. And the reason I put this up is to really highlight that although on the surface there's a lot of benefit for industry or for the who's making the profit in the short term, I would really stress that in the long term, everybody does lose from these practices. Naturally, patients are losing from the start because of the excessive prescriptions, the cost burden, and the health issues that they would face. But in the long term, healthcare professionals are also at risk of losing the trust that society places in them, which is really hard to regain. The pharmaceutical industry, there's also increasing discussions about the practices, the unethical practices that are being undertaken there. And this really does push patients into avenues of seeking care that are sometimes more unsafe because they can no longer trust their healthcare professionals. So I would say that we all have something to lose with the status quo. So these are the policy recommendations that I'm going to be discussing. They are focused on standard setting and capacity building. So the first one is about having a standardized curriculum that has ethics and ethical practice as at its heart. Now, this is essential for both the technical and ethical aspect of healthcare, which is essential. And I would stress here that while I know there's often bioethics is a module, we need to go beyond the discussions on, say, like organ transplant and abortion. This is not the ethics we're talking about. We are talking about the ethics and the ethical challenges that a healthcare professional faces when they are offered a kickback, or when they are asking for a kickback, or when they're in a situation where they'd like their hospital or clinic to have an air conditioner for the purpose of patient sort of welfare, but it comes with a relationship with industry that might be unethical. So these are real tangible issues that need doctors and healthcare professionals need to be equipped with navigating. And Mr. Ubaidullah talked about regulation. One of the key issues is that it's very difficult for a regulator to take action if 90% of the people that they are regulating, or 80%, or the majority, do not see that the rules are necessary or are actively engaging in rule breaking. No regulatory system can work. Regulations are meant to be for small proportions of people that are going against the rules. So there needs to be a sort of basic grounding in ethical practice that is currently missing. then linked to that is continuing medical education. If we take a step back and think about it, Pakistan really is an outlier, I have to say, in that after getting a medical qualification, one can practice for decades without requiring specific continuing medical education to update on the latest technologies, but also the latest rules, which again makes it more challenging for regulators without having a platform to bring people up to speed. So at the heart of technical and ethical healthcare is this continuing medical education, which is really the norm around the world. I realize there's a lot to be discussed here. We've been in discussions with doctors as well, and there's concerns about the burden. You know, doctors को पहले इतना काम होता है, फिर आप उनको अपने clinic से निकल के हम अब education करें. So this idea that, you know, doctors are really overburdened. And while we agree with that, there has to be a minimum standard of technical and ethical competence in order for doctors to be practicing safely, and it's in their interest as well as the patient's interest to do this. So I think this is one avenue in which practical ways to reduce the time burden while still meeting that necessity of having regular updates to doctors and other medical professionals is really essential. Now, of course, we can't just stop at medical professionals. We're here with a lot of industry leaders as well, and the managers and sales representatives that I would also put under healthcare professionals, because they play such a big role in imparting advice to doctors and currently are filling the gap in continuing medical education. So this huge cadre of healthcare professionals as well must have some training on ethical practice that's mandatory, that's regular, so that again there isn't this issue of the majority or a substantial minority undertaking practices in terms of giving incentives, the types of gifts and relationships that are being established being unethical. Then number 4, I've got 2 more to go. So this is number 4. So as well as building the awareness and having really strong education about ethical practice and the rules, we know that there needs to be strong regulations as well. The study that I referred to at the beginning, we found, as I mentioned, that 40% of GPs in Karachi were willing to take a bribe. The other part of that was through a randomized trial, which was published in one of the leading UK journals. We demonstrated that education alone only made a small change in their practices. So while education is a really important foundation, we'd say it's necessary, but it's not sufficient. There needed to be, or there needs to be, the stronger regulations and enforcement of them for real change to happen. So here, one of the steps could be that there need to be some fair mechanism for both patients and healthcare providers. So when there are instances of rule-breaking, unsafe practice, that those could be reported and dealt with. I realize this needs a lot of resources and it's not an easy one, but it's again a very, very common around the world, and it's quite essential for there to be that transparency and for there to be some concept that breaking rules and potentially causing harm to patients has some consequences. And linked to that, on the industry side, so this is the final recommendation to discuss, is about the pharmaceutical industry. So you're really stepping up and having some hard actions as well in terms of reporting of what they are doing. And so it's a level playing field for the many, many companies that are operating in Pakistan. What are the whistleblowing procedures in place? What are the complaints procedures that they have? And the access to a complaints policy. So this might be for patients to use or for other industry colleagues as well, because we know that even within the industry there are concerns about other companies and their lack of adherence to the rules. Now, this could be a way of self-regulation initially, but it's really important to discuss what the industry has in place across the board so that there is access to recourse if these rules are being broken. So as I said, these are not easy recommendations, but and we are here to discuss them and evolve them to a format that will be acceptable to the range of stakeholders here, and we really would value your input in coming up with some tangible actions. For the second half of the recommendations that we have, I'm handing over to my colleague Kashif.
Thank you, Dr. Mishal. Assalamu alaikum, everyone. I think Dr. Mishal set the tone for these recommendations very well. The second part of the recommendations that you see, they are mostly focused on the enforcement side. और enforcement में जो हम ज़्यादा focus हमने किया है, and I think it's important to say at the outset that the recommendations that you see on these screens and also in your folder, these are just recommendations that are coming out from our experience that revolves around engagement with the regulator, engagement with the health sector broadly, but also research that is grounded in informed evidence that you saw in the previous presentation. But the idea of today, I think, is how can we stakeholders from across different regulatory industry and healthcare professionals, how can we co-develop this roadmap? So the second part that I'm going to focus is more on the enforcement of the existing regulations. Now, हमारा जो Transparency International का different sectors में काम है, I think we look at healthcare also as any other sector. And for governance, I think the key focus that we have been putting through our work is कि जी अगर governance को आपने improve करना है तो digitization and disclosure of data is the key here. And I think what you will see in the 5 recommendations that I will be discussing is an underlying emphasis on the disclosure of data. And I think what we are also highlighting is कि जो एक बड़ा gap है पाकिस्तान के healthcare system में at the moment is this publicly available data. चाहे वो हम वफाकी सतह पर रेगुलेटर्स की बात करें या सूबाई सतह पर रेगुलेटर्स की बात करें, देयर इज नो पब्लिकली अवेलेबल डेटा ऑन ethical, safe medical practices by the doctors, by pharmaceutical companies, by healthcare professionals. What is needed कि अगर हम एक अपने healthcare system एक strong trust build करना चाहते हैं, और वो trust, again, there are various surveys which shows that when citizens' interaction with the healthcare takes place, the trust is really weak here. So what I think we have recommended on this is as a key focus कि it is important कि both the regulators at the federal and provincial level, they disclose this data more regularly on the type of actions that have been taken against the unethical practices and what corrective actions have been put in place. And there are 2 advantages of this data. A, it will, as I say, help in creating trust. But B, and more importantly, it will also create a level playing field for the pharmaceutical companies on how to ensure compliance with the existing ethical practices. So that's the key point that I want to make through first recommendation on the disclosure of data on the ethical practices and their compliance. The second is कि जब हम regulatory landscape की बात करते हैं, पाकिस्तान में drug regulatory authority एक बड़ा important regulator है. डॉक्टर बेस साहब ने काफ़ी जो है उन्होंने अपनी काम पे भी रोशनी डाली और काफ़ी एक insightful मेरा ख्याल insights भी दी कि how this regulatory framework can involve more. But I think what is really the gap here is also the capacity gap of DRAP. And this capacity gap, it underlies in 2 shapes. A, their sort of inspection and investigative powers when it comes to manufacturing practices, but also on the ethical side. और DRAP में जो हमने I think through our engagement at TI with DRAP also identified is also a gap of human resource capacity. So one of the key human resource capacity is the federal inspectors of drug. पिछले कई सालों से जो वफाकी सतह पे FIDs की appointment act has been lingering on. Just last month, 8 FIDs have been appointed, and I think it's an important question to brainstorm through this forum that for a country like where there are more than 500 or around 1,000 manufacturers, local importers, device manufacturers, can the 8 FIDs do their job? So the focus here is really how do we enhance the capacity of this existing regulator through recruitment of right technical capacity people. The third recommendation is on the pharmaceutical marketing. Now, pharmaceutical marketing, again, is the most sensitive area when it comes to ethical practices. There's a growing evidence, as Dr. Mishal also suggests, that how the promotional spending by the pharmaceutical companies, it incentivizes certain prescriptions, and it also incentivizes the unethical incentives that we often talk about or are reported that take place. What again we are focusing here is the strict enforcement of the existing rules. The rule says that the marketing expenses need to be disclosed, but there are only few companies who do that. There is a need for a strict enforcement of regular reporting by the pharmaceutical companies on their marketing expenditures. Now again, the advantage of having this regular reporting for the listed companies, again there are regulators where they can take place through their reporting. There are again two advantages. It will send a very clear signal on the transparency. Where is the money going? How the money, if is encouraging any unethical incentivizations. But there also it will create a level playing field on the compliance with these ethical marketing practices in place. So what we have recommended here is the rules that we have on the marketing, they should be strictly enforced across the board through regular reporting on the expenses. The fourth is more on the provincial side. अब सूबाई सतह पे जो हमारे regulator हैं, most importantly being the provincial quality control boards. The quality control boards again have the most important role when it comes to identification of the counterfeit drugs. Again, if you look at the quality boards reports, there is no data on their annual performance. There is no data on what kind of inspections have been taking place. There is no data on how many drugs have been seized, what penalties have been imposed. What we have recommended is for the provincial regulators such as Quality Control Board and also the area falling under the healthcare commissions is to have this data on annual basis being reported more rigorously. The idea again with this data reporting that it can make these quality control boards a very strong accountability mechanisms at the provincial level. And finally, I think the final recommendation is on strengthening the nutraceuticals. Now, हम जानते हैं कि पाकिस्तान में इस वक्त 50 से 60 हज़ार जो alternate medicines मौजूद हैं in form of nutraceuticals. These take place of the food supplements, homeo medicines. Currently, all these medicines are available in the market as part of the enlistment process. I think we'll take the advantage of the Dr. Ubaid Saab being here to also brief us during the open discussion of what procedure, and I think it's important to highlight कि ये regulation की शक्ल होने क्या चाहिए? Should it be with DRAP? और क्योंकि 2000 अब DRAP का जो एक्ट है 2012 में उसमें बड़ा क्लियर है कि जी लाइसेंसिंग और रजिस्ट्रेशन होनी है. 2014 से जो है न्यूट्रास्यूटिकल्स की जो पाकिस्तान में है वो एक इनलिस्टमेंट प्रोसेस के तहत जारी है. Now the danger of the enlistment process is really that these medicines are going on without their safety or testing or manufacturing practices. So the GMP practices that we highlight in the healthcare are really who is regulating there. So what we have pushed for is that all these enlistment processes should be stopped and they should be replaced with the enactment of the enlistment and the registration and licensing processes. Now it's also important to highlight here कि पिछले साल जुलाई 2024 में बलूचिस्तान हाई कोर्ट का इसके ऊपर फैसला था on a petition around price fixing. But this particular policy instrument is still something that is pending on the nutraceuticals. So the idea, I think the recommendation here really is that how do we strengthen the regulations around nutraceuticals so that these thousands of alternate medicines that are available in the market, they are also regulated from the safety point of view well. So maybe I'll stop here, and the next segment will open it for the forum to discuss, and also shed light on some of these 10 recommendations, and also if there are any areas that you feel should go into the final policy paper. Thank you.
Thank you, Professor Mishal and Mr. Kashif, for those comprehensive insights. These recommendations provide a solid foundation for strengthening governance, transparency, and ethical practice in the health and pharmaceutical sector. So taking this opportunity of these recommendations, we will now open the forum for the discussion on the draft recommendations. In the interest of time, I would request the comments be kept brief, and please introduce yourself when you speak. So forum is open for your comments and feedbacks on and initial reflections.
सबसे पहले congratulate for holding such a important event required, very much required. Pakistan is new to the regulation culture, particularly in health and nutrition. So I have two questions to understand the mechanism. It is a good opportunity for us to understand the dynamics, how the ethics and regulation works in Pakistan. How does draft ensure adherence to the corporate social responsibility of the pharmaceutical sector? Are they agreeing to that, and have we set some standards for them, and how do we regulate them? This is my first question. The second question is that we have seen, I'm a medical doctor as well, we have seen thousands of multi-vitamins and supplements being sold on the medical stores and the market, and mostly they are not the registered products. Everybody is carrying this bag, 1 or 2 bottles of some multivitamins or supplements which are not actually approved by any authority. So do we have any mechanism to regulate those at the medical store level? We regulate the prescription, it's okay, but do we have any mechanism that we could see the blue area and the major areas of the city, and now are actually the big pharmaceutical chains, they are selling those things without a say, without any restriction. Do we have any mechanism for that? These are my two questions. Thank you.
So this is a relatively informal interactive, just to say we'll be taking comments, we'll be discussing, so thank you. I think please go ahead, and I think so far we're doing okay. But we want to wait the mic is coming. We actually running slightly ahead, so it's good to have a bit more time for discussion. So at the moment we're going to be taking the questions, we'll be looking at a panel discussion we discuss, or you want, I think we'll take a few comments instead of all of these.
But if there are any key concerns and questions, we have a draft to operate.
Yeah, and maybe wait for the mic. Yeah, okay, but I think the mic is just coming.
And it's fine to speak without mic.
Okay, fine.
Thank you very much. Thank you very much. I think it is a sort of great initiative by the Transparency International on governance, medical ethics, quality of care, patient safety, ultimately trust, और ये सारी चीजें बड़ी इंटरलेक्ट है और बड़ी क्रिटिकल. देखना ये है कि what do they bring out of it. ये बड़ा अच्छा है कि Transparency International is working as a whistleblower. उसका असर होता है कि नहीं, जैसे कि ये और बात के टूटे न बेहिसी का तिलिस्म सदा देते रहो पत्थरों के सहरा में, बात करते रहना चाहिए, होती रहनी चाहिए. आप सब, I think everybody knows that before 2012 and 2010, the main regulators were the ministries and the provincial health departments. It was after the devolution that regulatory authority for drug regulatory authority and provincial healthcare commissions for the sake of regulating healthcare service delivery has been established. लेकिन मे बी इस हिस्ट्री में भी जानना मुनासिब होगा. By the way, my name is Dr. Mushtaq Slaria. I am Director Clinical Governance in Punjab Healthcare Commission. I am so sorry, I could have introduced earlier. तो जब कमीशंस बनने शुरू हुए तो मिनिस्ट्री अनफॉर्चुनेटली नॉट विद द पर्पस ऑफ annoying anybody, it was sort of thought कि ये शायद there is some rivalry going on. Some is being captured, which is basically their domain. Particularly, there were very rapid amendments in the Act of the PMDC. First commission was established in 2010-11. Immediately, the ministry, the PMDC got its act amended to also include healthcare provision in their act in their domain. दूसरी अमेंडमेंट 2015 में आई पीएमडीसी के एक्ट में, 2019 में there was something else, 2022-23 में. Currently, basically इस दौरान there have been number of changes going on, कभी ad hoc council, कभी दूसरी council. ये मैं बात कर रहा हूँ मेडिकल एजुकेशन के पॉइंट ऑफ व्यू से और हेल्थ केयर प्रोविजन के पॉइंट ऑफ व्यू से. तो वो जो बहुत सारी चेंजेस आई उसमें काउंसिल की वर्किंग में, दे हैव आल्सो कॉम्प्रोमाइज्ड मेडिकल एजुकेशन, पर्टिकुलरली सॉरी सर नाराज ना होइएगा, इन प्राइवेट सेक्टर मेडिकल एजुकेशन, और उसके साथ साथ जो फॉरेन ट्रेंड स्टूडेंट्स हैं, देयर इज नो कॉन्सेप्ट ऑफ मेडिकल एथिक्स, हेल्थ केयर सर्विस डिलीवरी स्टैंडर्ड्स in the curriculum which is being taught. And secondly, their clinical skills are compromised during this training. So I think this whole issue needs to be looked into holistically. एक दिन में शायद ये sensitization तो हो जाएगी, but definitely इसके ऊपर बहुत exertive और बहुत सारा काम करने की ज़रूरत होगी to curb this malpractices, both in the provision of healthcare services as well as prescription of practices. Prescription of medicine. अब जो आपने kickback की बात की, तो I think the research and development.
Sorry, in the interest of time,
I'm just concluding the last comment. The research and development fund of the pharmaceuticals should ideally go into a sort of research and development as such, not on excursion trips for the doctors, for the families, and for things like that. Well, I think they should stop sponsoring conferences which are not meant for educational purposes. There were other comments also, but due to shortage of time, I'll keep myself brief. Thank you.
Okay, we'll go around. I don't know, Rama, you can help me.
Dr. Rupina.
So while Dr. Meena, and just to summarize, because but the mic wasn't there, so आपने corporate social responsibility की बात की and how that can be, I'm saying, so I'm just summarizing, and आपने, you said medical education, so we'll come back to these themes. Dr. Rubina, फिर आपको, and then.
Thank you so much, Michelle. As your first point, we have been training and teaching bioethics in Nakan University. I have been doing that for more than 2 decades now, and it does make a difference. I think it makes a tremendous difference, not just a difference. The kind of intervention we did for this study was, one point in time, it was one intervention for a short duration, and I would look at it very positively at the results. Even then, 8 to 12% of the participants changed their prescribing patterns, and I think I was actually happy with that result. It was just a 2 hours intervention. So I think in all the discussions, the elephant in the room is absent mandatory bioethics education in Pakistan medical colleges. So it has been spoken about lately in the recent years and emphasized upon, but it's not mandatory. Most of the medical colleges are covering that aspect to that module by hiring a part-time Islamiyat teacher. Now, ethics is not religion. It's a stand-alone discipline on its own, with its own principles, its own frameworks, its own working points. And that's why when you do not teach the students right from wrong, how do you expect from them to intuitively know that how should they practice? If we are looking at changing the practices and behavior, the first point is making the education mandatory, and then providing a culture that is conducive and not deterring for the ethical behaviors. And only third thing is the regulation that comes in. If we do this in different sequence, then it will stay the foundation will stay very weak. And I'm going to just emphasize that even if it is done, and that is to be PMDC's responsibility to make bioethics mandatory, it should not be done in a tokenistic way. It should be, you should hire bioethics faculty, teach it, and most importantly, assess it, because the students will not give it any significance unless they are assessed on these.
Assalamu alaikum everyone. This is Nadeem Iqbal. I am from the Network for Consumer Protection. So I just have a couple of points to make, the quick one. First is like the patient groups that's missing from the whole debate. So there should be the involvement of patients at every level of the regulatory ladder. And particularly, we have observed that thing from different regulatory bodies. Whenever they are investigating anything, the complainant is missing. Who has made the complaint? So basically, these are the suo motu powers they are assuming, and then they just enhance their stick against the corporate sector. So this is the overall impression we are getting from there. So consumer redress. The second thing is consumer redress, what kind of complaints you have got, and also the prevention, how you have prevented that this complaint is not made again. So this is also very necessary, and the websites, information on the websites have to be there, and there has to be one template, because there has been some unreported, the decision or the verdict in the Supreme Court, something relating to that one. If a body which gets the license or which is under the regulation of the government, it's a quasi-government body. So the right to information also applies to that one, and they have to be proactively, sending out the information. Another important point is, like, we see the, the health regulation or sector isolated from the other sectors. Particularly, there have been, and instead of reinventing the wheel, there has been laws in Pakistan, like Competition Commission of Pakistan. It has recently fined heavily to a company which was selling Strepsil as a medicated product, though it's just like a toffee. So that was the investigation. So, these also needs to be addressed. So these are just some of my impression. And the last one, the UN has a guidelines for the consumer protection. These are universal guidelines approved by the UN General Assembly. So that also will looked into that one when you develop the consumer redress mechanism. Thank you.
There's one last point here, and I know you've been waiting for it. I'll just take this one and come to you. Thank you so much.
Yeah, sure. Assalamu alaikum. Good morning, everyone. This is Jahanzeb Sohail, Senior Health Economist, World Bank. Thanks to the organizer for organizing such an important event, and also for excellent recommendations by Professor Mishal and Mr. Kashif. I would like to share two thoughts on the recommendations. So number one, Mr. Kashif mentioned about the field officers are strengthening the DREB, which we all require, and we see that there's a sort of a must thing where we really need to focus on DREB and also healthcare commissions at the provincial level. So, but somehow my background is supporting, or let's say convincing me, that the biggest issue here is financing for this. What I meant to here is what we see that the public service delivery is roughly spending right now in this current fiscal year is up to 1100 or 1200 billion PKR. And there's a tiny portion from the Ministry of National Health Services. I would say tiny because considering the overall legislative list we are having at the federal level, so there's the coordination, regulatory, and a couple of other things. And what we see with the numbers back in 2022, we had 88 billion, and now because of right sizing, what we say, we have roughly half of that, 45 or 47 billion. And I'm 100% sure that it won't be much, Dr. Obed can correct me, more than 1 or 2 billion for this. And considering at the ground side, strengthening of the DREP related to the pharmaceutical industry, which is roughly like 700 or more actors who are working here, it's a very, very difficult task. So first thing, we really need to work on that how we can advocate, invest more on this area. Definitely there could be other ways to generate the funds for that. Secondly, Madam, you mentioned very important point, and we have been suffering this ethical practices issues, the incentivization of the doctor, and what we see from the economist side, supplier-induced demand, where the one side party doesn't know much and totally relying on the other side party, and it's up to him what he's going to or she's going to prescribe. In this case, what we see, the recommendations are very pertinent, but what India did, and then unfortunately, it's not really legal enforcement there, but the Ministry of Chemicals introduced a uniform code system that how those practices can be rolled out. It didn't fly well, but we have another example of South Africa where it did fly. And we have the marketing association, I wrote down the name, Marketing Authority Code. So if you Google it, it is working there. These are the steps or codes which are written there, which is run by that particular authority, that how we can take care of those, the inducement and also the reports and complaints and all those things. This code can be the part of DREP, where it can get the legal binding as well through the provincial government and also the ministry enforcement, and this can act working. Otherwise, we will be debating and discussing for years and years before and years and years after as well. Over. Thank you.
Do we have mic on this side?
Who wants to? Okay, sure.
Assalamu alaikum everybody and good morning. I'm Dr. Hina Javed. I'm currently heading the Department of Family Medicine at Health Services Academy, Islamabad. Thank you very much for the opportunity, Professor Mishal Khan. It was a great presentation. The word primary care was missing. And I think that is the missing link. You've talked about cost effectiveness. There is huge evidence primary care is cost effective. And and I'll leave a question for the audience here. Do you think not having a primary care is leading to waste of resources? Which answer to it is a yes. Somebody mentioned a huge elephant in the room. Are we addressing it? So that's one thing. We talked about training. There are a number of postgraduate trainings in medicine, in various specialties, which are lacking robust structured training. We know that. Again, a big elephant in the room. Are we willing to talk about it? That's another issue. We talked, the last comment would be, in those trainings that are currently happening, our residents who are undergoing training, is there a lack of leadership? The answer is a yes. Are we teaching that? Is that part of the curriculum, the hidden curriculum? Antimicrobial resistance, we've talked about it, right, left, and center. We know it exists. What's stopping us in having a prescription that is issued by a qualified, trained, registered primary care practitioner? Why the regulation does not exist, or if it exists, why it's not applied. And yes, doctors should be, primary care physicians, faculty, academia should be part of policy making, advocacy, and leadership as well. Thank you.
Thank you very much, Dr. Mishal, for the invitation. I'm Dr. Razia Fatma. I've been with the National TB Control Program and Common Management Unit for last couple of decades. I've been the national coordinator, and currently I'm a consultant with UNOPS on TB strategy with the Global Fund grants application, and I'm also technical director with the Health Solutions International and a chair of Ethics Advisory Group, which is an international group for the International Union Against TB and Lung Diseases. So first I want to congratulate you for the excellent dissemination. I think all the points you have highlighted with all the colleagues from Transparency International, they are a true reflection of what is going on in the country. So one of the article which you have shown, and it was a great interest for me as well, and I think this is again a true reflection about the corruptions in the medical corruption which is linked to the prescription. So this is very, very much interesting. And my question is, how do we regulate this? Because it's like an ethical crisis, and it's going bigger and bigger. So how do we really regulate this? And the other question is about the quality assurance, because as what we have seen in TB world, that there used to be an encouragement for the international procurement from the Global Fund. But now they say that you have to enhance your capacities and you have to capacitate yourself to produce drugs in the country, and these drugs should be available. So how about the quality assurance, which is a big, big question mark for a new drug, or let's say for the TB drug to enter in the market, which is manufactured locally? Thank you.
Assalamu alaikum. मेरा नाम ज़ुबैर फैसल अब्बासी है, and I work with Impact Research International. The regulatory ensemble of Pakistan is perhaps for some components of these health regulation or pharmaceutical regulation is federalized. Now, federal government has authority which they have obtained from the provincial assemblies to regulate at the federal level. But at the same time, we see that provincial governments are also establishing some of the infrastructure in support of these kind of regulations. The point which I want to make is about how to address complaints. Because to address certain complaints, you need to have laboratory testing facility. We really need to know that how DRAP is actually managing it, and do they have that real capacity to respond to the complaints which come with preparation of different salts and nutraceutical and others. Recently, we saw that government of Punjab they have established a not regulatory but authority which is called Agriculture, Food and Drug Authority, and they have made enormous investment in the technological or laboratory related equipment. So perhaps there is a need to look at the federal structures, how these provinces and different regions can cooperate with one another, especially while handling complaints against pharmaceutical companies and address questions of related to these nutraceuticals. Thank you very much.
Thank you. Thank you, Zubair Saab. I'll hand over to Dr. Farooq Bukhari Saab from PPMA, if we can have your comments as well. Dr. Saab, oh.
Assalamualaikum ji. Dear colleagues, industry leaders, DRAP officials, and of course from the journalist fraternity as well, and foremost TIP, Transparency International Pakistan. First of all, I would like to congratulate and appreciate the effort they have taken towards organizing such an event where we can actually debate about this policy, which is more relating to the public domain, which is of course the most centralized argument all the time. And I hope we can formulate and approach a balanced policy, which of course not just empowers few stakeholders or just one stakeholder or providing undue leverage. Firstly, would like to touch upon benefits and the risk of such a policy from the industry point of view, and of course, which I'm sure our distinguished guests and speakers would highlight much more, elaborate upon it more, and eloquent questions from moderators. From industry, for instance, it will foster more of a genuine innovative based product and thrust a culture of efficacy and R&D and targeted medicine rather than influencing the domain of healthcare officials. And moreover, as an industry leader, I would like to comment and also highlight upon that we as industry think and are very sure that the ethical practice, or whatever we are talking about here, is less expensive for us as a cost burden for us for promoting and not just educating, but again, you can say influencing, is much more expensive than ethics. So again, we are with this narrative that ethical marketing and more chance should be given to the qualitative based manufacturers, rather people who are more over towards gaining influence through other means. And more importantly, our public image, which is always at the stake and helm of our media, and of course, because they're very much linked with the public opinion, and henceforth improving our public image by this policy and promoting and suggesting the narrative of ethical marketing practices by the pharma industry. And of course, as we all know, the most sensitive part is the patient, which is the end user, and we all should formulate a policy keeping in the patient in mind. So it could have and reach quality medicines, not just cheaper medicines or less expensive medicines, but quality medicines. That's what our basis of this August gathering should be. And on that note, I would like to proudly claim as well that we as industry, pharma industry, are increasing our foothold in the export market, mainly CIS countries, South Asia and Africa. And we have grown around 34% in our exports, which is again a testament that the world is reaching towards medicine, which is of course on the basis of quality, not on the basis of influential, because as you understand, when we go into foreign market, we are less influential than their local people or language barriers, and of course we don't know much about it. But again, that is a testament that our narrative of building and making our capacity more towards qualitative, so hence we are promoting that. And effectively producing new products. Moreover, the proof that is most of our industry leaders and some of our companies, which I can proudly say, are attaining WHO, PICS, EMA, MHRA, and many other international recognition, which hence is a testament to our commitment towards quality. Lastly, as we as individual leaders and policy makers, regulators, and media, it is difficult to differentiate there's some thin lines between these, One is collaboration versus influence. How do you define or differentiate between a collaborative nature or an influencing nature? How would you define that? And I'm sure once we have this panel discussion, we'll be much wiser to understand that. Or education versus promotional activities. How can you define what is education nature and what is more of a promotional activity? We need to formulate between these lines, and sometimes, it's difficult to come towards a logical end. But again, formulating or, is just half of the battle. Formulating a policy is half of the battle. Half the battle has to be fought towards implementing, which I'm sure DRAP is doing a wonderful job, and of course we are always with them. And, okay, I'll just come to the last point then. Lastly, with the narrative, we stand by the narrative of ethical marketing and self-evolving policy. And moreover, there's some comments. I would like to take few seconds to say on that. Recommendations would be CMA training, continuing medical education as being an educationist myself as well. I would like to promote that. And of course, from the hospital point of view, institution point of view, I think we need to create a formulary committee, independent committee that could recommend drugs that are used in a particular, hospital. And lastly, of course, we are open for full financial disclosure for our activities as well. And thank you very much for your patience. Thank you.
Thank you. Sardar sir, we had a comment from you, Sardar Shabir sir, also PPA, if you can add, and also I think from the Parliamentary Secretary to the Health, if you can have some comments. Do we have more? Do you want to add some?
Thank you very much. My name is Vakar Bhatti, and I'm a health journalist. And I'm writing on this issue of unethical marketing practices, unethical prescriptions, and I've been a victim to this also. I have a question, rather two questions. Pehla, who is going to decide that a prescription is unethical? ये एक assumption हो सकती है, मेरी हो सकती है as a patient, मैंने इस पे लिखा भी है, लेकिन who will establish that a prescription is unethical? मतलब clinicians, he has hundreds of reasons of writing 2-3 nutraceuticals, 2-3 painkillers, 2-3 antibiotics. Who is going to establish that? ये सबसे पहला मेरा सवाल है कि ये establish कौन करेगा? First. Secondly, and that is more important, I went to every door. I knocked every door. DRAP, मैंने कहा जी ये unethical prescription. And they said कि we only deal with pharmaceutical. I went to PMDC and they said nobody came to us with a complaint. कोई complaint तो मैं कैसे complain करूँगा? I'm a layman, मैं जाहिल आदमी, मुझे क्या पता? डॉक्टर साहब मेरे खुदा हैं, उन्होंने जो लिखा है मैं उनको कैसे मैं बताऊँ? और I don't know कि whether we have healthcare commissions here, फेडरल वाला और प्रोविंशियल वाले तो सर बैठे हुए हैं, और आई वेंट टू देम एंड दे सेड के लॉ में नहीं लिखा हुआ हमारे ये, और उन्होंने भी यही कहा कि हु विल एस्टैब्लिश के ये जो है अनएथिकल प्रिस्क्रिप्शन है. तो ये कुछ बेसिक क्वेश्चंस हैं, कुछ बेसिक सवालात हैं, पहले इन पे बात कर लीजिए, फिर कवानीन पे जाइएगा और बातें कीजिएगा. थैंक यू वेरी मच.
थैंक यू वकार साहब. आई थिंक
I think that's a really important point. Waqar Sahab, quickly I can respond. I know this. The way that conflict of interest deals with this is, आप सही कह रहे हैं, it's not possible to say कि ये prescription गलत है. It's very difficult. So what you need is for your doctor or healthcare provider to be unbiased. You regulate at that point. You need to know that they have no reason to be overprescribing, because दूसरे stage पे करना बहुत मुश्किल है. So that is a quick answer, but we must discuss more. Kash Saab, will you take 5 minutes left and then...
More, and I think maybe because there were some comments that might need response. So maybe we can use these 5-7 minutes to have a response from Dr. Obaid and Dr. Azwan, PMDC and DRAP.
Thank you very much, colleagues, for valley of questions. In fact, if we see legislation, previously it was Drug Act, followed by DRAP Act 2012. These both legislations are hybrid model legislation. Alone, Drug Regulatory Authority of Pakistan is not responsible for the regulatory framework. If we see, there are 9 regulatory functions which are supposed to be done by any regulatory authority of the world: licensing, registration, marketing authorization, market control, and so on and on. Out of these 9 regulatory authorities, there are 3 regulatory functions which are solely to be done by DRAP, and rest of, rather 4 functions. Rest of the 5 functions are to be done by DRAP and provincial government together. And sales, storage, distribution is exclusively being done by the provincial governments. So it is a basically regulatory framework where we are right now working. And this regulatory framework has been vetted by our World Health Organization as well, when they were here for the audit of our organization as well. So by and large, if we see that post-marketing surveillance, market control mechanism, lab testing, it is a hybrid regime where provincial governments and DRAP both regulate the function. There was a question about the provincial drug testing laboratories. By and large, if we see that there are 11 drug testing laboratories across the country, one is being supervised by DRAP, being the federal laboratory that is based at Karachi, Central Drugs Laboratory. Rest, every province have their own regulatory testing laboratory where their provincial inspectors take the sample, whether it's a regulatory testing or testing during their procurement process, and they used to send and they analyze. And at the same time, if we see that statutory board for the decision of all these samples, there are 2 parts. One to be done by the federal government, that is our registration board. Second part is the provincial quality control board. And when I say provincial quality control board, then we have 7 entities, 4 provinces, ICT, AJK, and GB. So these are the 7 entities. Every province have its own drug sale rules, every province have its own drug testing laboratories and supervised by the quality control boards. So all the violations of all these things of the testing and surveillance go to the quality control board, and in case of some violation, there are two options. Either it goes to DRAP for taking action against the license or registration, but by and large, mostly these go to the courts, drug courts which have been established in the respective provinces. So that is the one part where all the provincial regime works. At the same time, provincial, there was a talk about the human resource component. So human resource component is again same one, that provincial inspectors are responsible for the supervision of sales, students, and distribution. And if we see, there are about 3,000 inspectors across the country. We are talking about 500, 600 people working in DRAP, you are right, but these 500 or 600 people are for the secretariat work. When we say that who is the post-marketing surveillance person, these are the provincial governments, and by and large, in all these 7 entities, there are about 3,000 inspectors working at the tehsil level. And these are responsible for the monitoring of sales, storage, and distribution. As far as manufacturing supervision is concerned, it is being done by DRAP. We really, we admit that there is a shortage of human resource, and if you say who is the best regulatory authority of the world, we say US FDA. 2 months back, I happened to interact with them, and I posed 3 questions to them. My first question was, what is your major problem, challenge? They said human resource. US FDA with 20,000 people in their work, although they are performing other activities, they are still facing human resource constraint. So we have same problem, but by and large, we are now inducting some more people, about 150 people in our HR component as well. So that is the one part where we are right now working. As far as important thing is concerned, how we can strengthen our national regulatory system. We can strengthen our national regulatory system by only by having international benchmarking. Otherwise, it's very difficult for any regulatory authority or any, not only, I'm not talking about the drug regulatory authority, any regulatory authority in the country to have the, to streamline their systems. So for that purpose, DRAP was, during last 5 years, we were lastly audited by the World Health Organization in 2023. And they visited DRAP, provincial governments, and definitely it's not an easy task because we were being audited on the basis of an international standards of the global benchmarking tool. And
sir, only 1 minute left.
Sure. So we are very near to the all the processes which have been identified, and by and large, if we say where we were stuck up, that time our benchmarking result was that we achieved 83% of the score, but definitely there are some cross-cutting functions because they say that all the functions which are being done by the provinces, they should be harmonized. Now, right now we are working with the provincial governments, so their function should be harmonized, and we are expecting that in Q2 2026 or Q2 2026, we will be finally audited, and then we can say that our regulatory system is accredited. At the same time, out of 11, 6 of our labs are WHO pre-qualified, and this figure is one of the largest figure of the lab testing in our region as well. Thank you very much.
Sir, we have to go to the panelists.
अगर मैं इनको respond कर दूं, CSR is not the responsibility of the regulatory authority. CSR is the responsibility of the company, and DRAP or any government department don't do the CSR. It is the basic responsibility of any company, pharmaceutical company, or any other organization who is doing business to do the CSR.
मैं जस्ट 30 सेकेंड्स वकार भट्टी साहब, बड़ा अच्छा सवाल था। कार्डियक स्टंट केस में देयर इज अ जजमेंट ऑफ द सुप्रीम कोर्ट, और उन्होंने बड़ा क्लियरली कहा है कि किसकी ओपिनियन मैटर करेगी। सुप्रीम कोर्ट ने मिनिस्ट्री ऑफ हेल्थ को बुलाया, फेडरल प्रोविंशियल हेल्थ डिपार्टमेंट भी आए, ड्रैप भी था, हेल्थ केयर कमीशन भी थे, और उस जजमेंट में क्लियरली वो लिखा हुआ है कि जो रेलेवेंट एसोसिएशन है ना, क्लिनिकल एसोसिएशन रेलेवेंट, उसकी ओपिनियन प्रिवेल करेगी. अगर कार्डियक डिजीज है तो कार्डियोलॉजी की जो एसोसिएशन है, बिकॉज एक्सपर्ट्स का काम है ये जज करना कि ये प्रिस्क्रिप्शन ठीक है कि नहीं. पाकिस्तान अकेडमी ऑफ फैमिली फिजिशियंस हैं, जीपी की अगर प्रैक्टिस का मसला है, सो इट इज द रेलेवेंट. सो रेलेवेंट क्लिनिकल एसोसिएशन विच इज रजिस्टर्ड, विच हैज अ प्रॉपर रेगुलेशन विद इन देमसेल्फ, दे आर द वन, like in diabetes case, ADA, American Diabetic, look what happens in US. All the clinical associations, they are the ones who take the SOPs and they make all the guidelines. So in Pakistan also, you need to involve them for their opinion. Thank you.
Assalamu alaikum. I'm Professor Rizwan Taj, President of the Pakistan Medical Dental Council. दो तीन चीज़ें, just answer the 2-3 areas that you've all been interested in. First of all, bioethics has been my pet topic as well. I've been part of the International Bioethics Chair for the past 15 years. And I made a curriculum about 5 years back, a comprehensive curriculum, and presented it to PMDC. But unfortunately, at that time, it was not included. So now, since we've been in saddle for the last 2.5 years, it has taken us 1.5 years to completely revise our curriculum, and bioethics is very much part of it from day one. And we have completely overhauled the curriculum in terms of international guidelines and World Federation recommendations. Then the second thing is that second question was about the areas where ethical practice is involved. So we have a very robust ethical committee. It's called the disciplinary committee, and it rotates from city to city depending on the number of cases. So in the last 2 years, we have processed about 300 cases, and most of these cases are related to professional negligence. While the health regulatory authority is to do with the registration of clinics, doctors, hospitals, we get cases of professional negligence or any complaint against any irregular practice. If it's a signed complaint and a genuine complaint, it goes to the disciplinary committee. And we have cancelled many licenses, not cancelled, but given them 3 or 4 years, 5 years suspension. So again, we are looking at that part as well, and so you just be assured that every area within the PMDC working has completely changed in the last 2.5 years. Thank you.
Mic clear. Thank you everyone who had shared their reflection. Your inputs have been well noted. For participants who have not yet had the opportunity to share their views, there will be further opportunities in upcoming sessions. We will now move toward our first panel discussion. Following this panel, we will have a networking tea break. But first, allow me to invite our moderator and introduce me to our panel discussion panel. Our first moderator discussion explores professional practice standards and capacity building, moderated by Professor Samin Siddiqui of Aga Khan University, a leading expert in health policy and system strengthening. Joining him on the panel are Professor Dr. Rizwan Taj, President of the Pakistan Medical and Dental Council, bringing decades of leadership in medical education, accreditation and professional regulation. Mr. Zishan Nazir, Director of Quality Control at TRIP, overseeing compliance, testing and regulatory enforcement in the pharmaceuticals. Dr. Usman Waheed, Central Executive Committee member of the Pakistan Pharmaceutical Manufacturers Association with extensive experience in the industry policy and pharmaceutical development. Dr. Amir Jafri, Professor at the Center of Biomedical Ethics and Culture, Karachi, specialization in bioethics, professional practice and patient safety. I now hand over to the Professor Siddiqui to lead the discussion.
Okay, thank you so much. Please, Professor. The other panelists. Unfortunately, they're all males, so that's something which needs to be more careful.
Gender bias.
But, Assalamu alaikum and the host. I think the panel has been introduced. And मेरी आवाज आ रही है आपको through the microphone? Yeah.
मेरी आवाज आ रही है?
Ji, so before, so the panel has been, but before we start the panel, let me make a point which I think is important. And I think it refers to the paper that has been published that you presented, Mishal, and I'm a bit surprised it was not shared with the group. I think that's a landmark paper. It's not just another paper. It's not just another study. I mean, wo jo study ki gayi hai, that is not easy to do in any country of the world, because you go to these practitioners and you see how they practice in terms of the ethics and so on and so forth. So I would strongly encourage, and that is the evidence, that is the genesis of why we are here today. Because that is the paper which says 40% of our physicians or our practitioners are engaged in unethical practices for all sorts of reasons. And so I think that's what we are. So this is not about the review of DRAP or PMDC or healthcare commissions. It is about a challenge that we face in our country, and that is that there is a huge challenge of unethical practices, and there is a strong evidence, and how we can collectively make a difference to make an impact on how we reduced this very recalcitrant, very stubborn problem that exists. So that's what this panel is about. I'm absolutely delighted, and I'm absolutely privileged to have distinguished colleagues from various sectors and various institutions and organizations. And I'm going to go straight, in the interest of time, into the panel conversation. Professor Rizwan, who is, of course, not only just the president, but a leading professor of psychiatry, the head of the department. I think you have also been a dean of the Postgraduate Medical College, so he has all sorts of experience at all levels. So, sir, for you, the first question is, if I can start, is that what are the key challenges, but more importantly, what steps the PMDC is taking to ensure professional practice standards, which could be followed by physicians and dentists in Pakistan, with a particular focus on ethics of medical practice?
Right. What happened was, when we took over in 2.5 years back, we received, within 2 weeks, we received a directive from the Prime Minister House that we were to immediately start working on the World Federation of Medical Education registration. Now, at that time, I had no idea what was involved in that. As we went through the documents of the World Federation, we realized that it involved every part of our working on governance and ethical practice and everything. So I think it was an eye-opener for me that we were lagging behind in many areas. And that included ethical practice, curriculum, regulations, our processes, our procedures, our day-to-day working, everything. So we started working on it, and we realized that we would not meet the standards with the current level of regulations, and the WFME would not be happy with that. So we started communication with the World Federation, and we said, this is what is happening at the moment, this is our curriculum, this is our standards, this is our working, this is our governance working, and this is what we are going to plan to implement in the next 2 years. So they said, we are fine with that. You just go along with what is happening now and what changes you have brought in the next few months. And then we will inspect that, and we will listen to you, and we will see what you are planning to do. So we started the process of, again, to revamp every aspect of our working. And we were very successful, and because we were under pressure to do it as soon as possible, that really helped. So within a record time of 7 months, we had achieved the WFME standards. And then the inspectors came, they visited us, they visited 5 colleges, they sat in all our meetings where we were making major decisions. And they were very happy, and we got very good news in the following January, that we had achieved accreditation within a record time of 7 months. And with minimum expense. So that was very important for us. Second point about your practice and ethical practice, the problem is that the CME has been offline. It started at one stage in PMDC, and Sulari Saab abhi keh rahe the ki every government that comes, everything changes, and then it's all instability, new policies coming. At least we had a good piece of time in the last 2.5 years to develop everything. So we are actively working on CME, and that would include the ethical practice as well. So we are concerned, at the moment we have 400,000 doctors registered with us. So we want them to be part of the CME, and we are going to link the licensure with the CMERs. So we have signed an agreement with the American Accreditation Council for Continuous Medical Education, and they were here about 3 months ago, and they gave us a very beautiful and comprehensive snapshot of what we are supposed to do. And we are actually in the middle of that. We are going to start a pilot very soon, and then start implementing. And at the same time, we are establishing a digital portal for the registration of CME. And one of the mandatory points would be the ethical practice in the CME, which doctors who are currently in practice and they have been renewing their license and never looked at any book or not upgraded themselves with their knowledge in their field, all of that will be part of that, and we will only register credible universities who offer CME. So that part is also covered.
Thank you very much. It's very encouraging to hear what you have said, Professor Vantaj. But really, we have been hearing this for many years, to be honest with you. I mean, I'm an old-timer, as you can see, and I've been hearing it for 2 decades. So when do you actually think this is going to get into the phase of, because, you know, it's time that we really went from what to do, how to do it, and actually to show it. So are we moving in that direction? So that by next
absolutely. The pilot is going to be for 3 months, and after that we are going to roll it out across the universities across Pakistan and ask them to register with us with their programs, and we'll give them the guidelines and the hours and mandatory hours and everything else, and then we'll go to the council for approval to link the licensure with the renewal of the licensure with the CMERs. I think it's very doable. I don't envisage any.
So you think next year we should see something happening on ground?
Absolutely.
And it's going to be mandatory?
It's going to be mandatory,
okay,
yes.
Great. So this is very, very encouraging, and we hope that we can really see this actually happening, because I think it will have a huge impact. May I move to our next panelist, Mr. Zishan Nazir Saab. So, what in your experience are the challenges, and what measures does DRAP take along with its, and I don't want to miss the provincial drug authorities, because I think they also have a lot of role in this, you know, to ensure professional standards of practice in the pharmaceutical sector. PMDC ne to chalo dekha na, from the medical and the dentist and all, the pharmaceutical sector, and how effective these are actually.
Thank you very much. Initially, actually, we were facing the old Drug Act, which was replaced with the DRAP Act, which covers all the therapeutic goods. Actually, in Drug Act, there was only a chapter of medicines, pharmaceuticals.
In the 1976 Drug Act, are you
exactly. Yeah. And now in DRAP Act, there's therapeutic goods. We can talk about the medical devices, pharmaceutical products, and the OTC products as well. We have the old system of file marking like that, and coordination with the provincial governments through writing the letters, which sometimes misplaced during the dark procedures. Alhamdulillah, after digital transformation, we switched over the totally paperless working. Alhamdulillah, as of today, we are having 13 divisions in the DRAP, out of which 8 are technical divisions, and out of 8, 7 are totally digital. There's no paper usage, even in coordination with the pharmaceuticals or with the provincial governments. And the one division, which is the health and OTC, will be shifted in the next 2 months. It is as per the directive of the Honorable Prime Minister of Pakistan. Alhamdulillah, we are able to replace the old Schedule B2 LRA rules with the PICS guidelines, a pharmaceutical inspection cooperation system, which is an international system for the provision of safe, effective, and therapeutic goods across the country. So we would be able to harmonize our system with the international practices.
So Zishan Saab, dekhein, the DRAP has done good work, and we acknowledge 2012 mein ye shed create hui thi, if I remember correctly, 13 saal ho gaye hain, and it's a big move. लेकिन what I would like to see is, so you have maybe federal drug inspectors, I'm sure they are inspectors at the provincial level. लेकिन ये आपके arm, they are your field arms.
Yes.
What and how effective are these? How merit-based these are? How competent these are? What is the level of their integrity? देखिए यहाँ पे अगर जब होगा तब जाके हमारे practices में कोई सचमुच फर्क आएगा. So what are they do? They are your field arm. They are the people who are the eyes and ears of DRAP and provincial authorities. तो इनका क्या role है? How do you monitor them? How effective they are? And what impact are they having on improving ethical practices in the country? That's really for me the heart of the problem, you know.
Right. Actually, Obasur told us that we have appointed 8 federal inspectors last month. There's a very long procedure. All the officers which were nominated for the provision of FIDs, they passed through a detailed scrutiny by the relevant agencies. And after clearance from all those agencies, these 8 inspectors are finalized and appointed as Federal Inspector of Drugs by the Cabinet Division Prime Minister of Pakistan. If we talk about the provincial team, you know that there are about 3,000 officers, provincial inspectors working in there.
3,000?
Yeah, 3,000. Wow. Across the Pakistan, there are 3,000 inspectors which are working in the Tehsil level and district level and divisional level. They have their own procedure. Because if we talk about the appointment of the Federal Inspector of Drugs, they must be appointed by the federal government, Prime Minister and his full cabinet. While if we talk about the provincial inspector, they are appointed by the provincial governments. So I'm not sure about the procedure, how they appoint them, or what about their procedure for to check their integrity, like things.
ठीक है, I mean, this is really something to be looked into, because if with 3,000, that's news to me, कि 3,000 हमारे inspectors हैं field में, and if they're doing a good job, then I can assure you we'll make a difference. But of course, if it is just the run-of-the-mill kind of thing, then of course, and it can also be counterproductive sometimes if these people are not monitored. But anyway, thank you for your response. अभी इस पे आगे भी थोड़ी सी मौका टाइम होगा तो बात करेंगे. I'm going to now turn to our colleague from Firosans. Mr. Dr. Usman Wahid Sahab, and thank you for being here and also for responding to my messages. So the question again for you, because you are representing the PPMA, if I'm right. And so how does the PPMA ensure the annual training of the pharmaceutical companies and the sales representatives particularly and their managers on ethical marketing, and what contributions can the pharmaceutical industry actually make or is making to curb these unethical practices? I'm sure you have सवाल से पहले भी बहुत दफा पूछा जा चुका होगा, but it's important that you respond to this.
Hey, thank you, Dr. Saab. And full disclosure, I'm not a doctor. I'm at best a quack.
Okay, I was.
But this issue is it's an existential challenge for a country like Pakistan.
Absolutely.
And when the study came out, we had a conversation with Dr. Mishal and her team. Then we had a physical convening of Pharma Bureau, PPMA, at AKU to discuss a possible roadmap of how we can strengthen our systems for ethical promotion of medicines. So the good news is that, as I think Dr. Rubina also mentioned, it was only 12% of respondents in that study who had a positive response to that training, but there was one very small intervention. So I think really the core of the challenge is how can we make this effort sustainable, and how can we make sure we involve all the stakeholders. And that's what we've been grappling with. We've got the basic infrastructure. There's a DRAP rules that were implemented in 2021 around ethical promotion of pharmaceuticals. They pretty much draw from global best practices, whether it's the IFPMA code, whether it's WHO guidelines. So all the materials are pretty much there. What is needed is a sustained effort to disseminate this knowledge, to self-police and regulate wherever possible, and to also strengthen systems of enforcement, whether it's through PMDC, the healthcare commissions. Because the industry is only one player, DRAP is only one regulator. You need actually a coalition of stakeholders. And I think a colleague from the World Bank mentioned South Africa, where they have a medical code authority, Medicines Code Authority. And the secret to success of that effort in South Africa, as well as this, Mexico also has had a lot of success in this, is the fact that these authorities have all the stakeholders involved at one seat of the table.
Come to that.
So at the level of the PPMA, what we've done so far is that we have developed an internal consensus to have an ethics committee, and that will have two very clear functions. One is to internally disseminate best practices. So where we stand today is that individual companies the responsible companies do have an annual process of training of all their medical representatives. These trainings are documented, they're audited as well. But at an association level, what this committee will do is disseminate those best practices to across our membership. One challenge is that our membership is about 250, whereas there are 650 to 700 active. So we only represent a third of the industry. So how can we have an effective outreach method where we work with partners, whether it's CBEC or the Health Services Academy? I think we're very fortunate that on that front also, just taking CBEC as an example, it's known beyond Pakistan for the excellence of the work it's doing. So the curricula are there, the mechanisms are there, we just need to work together to enforce them. So internally yoga, and then externally also, this committee will look for opportunities to work with whether it's the PMDC, to support awareness sessions at medical colleges and universities, specifically around ethics.
Sure.
And I think that will be the beginning of something more sustainable.
Start again. So I know that you have your code of ethics, but not all are registered. But there's something which is, I would say, self-regulation. I mean, we are waiting for the government to come and the drug draft comes. But and I think a lot of countries have actually made progress through self-regulation. And I certainly know many, So is there any thinking on self-regulation, and how do you monitor yourself, and how do you censure some of the companies which are really not? So इसमें government के involvement के बगैर भी हम कुछ as, responsible associations कुछ सोच सकते हैं, कुछ कर सकते हैं इसके बाद?
जी, तो ये जो मैं आपको formal structure within the association बताया था, specifically exactly 4 things like this, not just awareness and dissemination, but also self-regulation, sharing best practices, but also calling out bad practices.
And that it would be somehow the association will find a way to inform or ensure that a particular agency. So do you have a mechanism to monitor the functioning from an ethical standpoint of your registered companies?
See, membership is voluntary, so compliance is voluntary. But we don't have enforcement powers, but what we can do is highlight good examples, and by doing that, reinforce.
No, I appreciate that very much, that what you're doing, but I'm just trying to see what could be done and what could be done out of the box to be able to make a difference to these. So thank you very much. I think we'll come back on a few more of these points. So I'll now come to Professor Amir Jafri Sahab. Last but not the least, so you of course represent the center at SIUT, which does a lot of work on training and practice. So my question to you is that, of course, what are you doing currently to promote those practices, which I'm sure you're doing a lot. But what can be done at the institutional level, especially to enhance the adherence to principles that guide the behavior of healthcare professionals, focusing on patient well-being and eventually moving towards a fairer health system?
Yeah, thank you for the question. I think the one success of this particular forum is that the PMDC and the bioethics educators are sitting next to each other. Yeah, so that is an essential ingredient, a connection towards the ethical physician that you're talking about, self-regulation, and etc. All of these come when you have the physician or the doctor or the health professional who knows what is right from wrong. So वकार भट्टी साहब का जो सवाल था, वो क्यों लिखता है 12 दवाइयाँ? Perhaps he doesn't know enough, और गाइडलाइंस नहीं है, बहुत सारी चीजें. So गाइडलाइंस होने के बावजूद भी the person has to know the right from the wrong. उस चीज के लिए I am delighted that PMDC has ethics in its crosshair right now, and CMEs etc. will help, but उससे बात नहीं बनेगी. What we require and what we are doing through the center, of course, center तो एक छोटी सी जगह है, 4 faculty members हैं SIUT के अंदर, Center of Biomedical Ethics and Culture, वहाँ और बहुत से लोगों के मिल मिला के हम लोग we are doing a diploma program and a master's program for the past 20 years now. The Khan University has now got a funded program from the NIH doing a master's. So we are training, but वो बहुत थोड़े से लोग हैं. And उनकी recognition, so our diplomas and our degrees are recognized by HEC, but not by the PMDC right now. हमारे जो PMDC का certificate है, मेरे PMDC का certificate कोई bioethics की degree नहीं है, मैं surgeon हूँ, and that's it. So that has to be actually entered somehow into our portfolio also, that PMDC recognizes bioethics as a entity in itself, like you did, and you have an example, sir, like we did 20 years ago, medical education का किसी को जिक्र नहीं था. Everybody was a medical educationist, सब पढ़ाते थे, मगर किसी को नहीं आता था पढ़ाना, and we are all, हमारे जो seniors थे, they were all quite offended कि हमको आप सिखा रहे हैं कि हम कैसे पढ़ाएं. But yes, PMD said, no, you have to have certification, masters, and all of the PhDs, mashallah, कितने हमारे पास हैं. You made sure that every institution, medical institution, has a bioethics, a medical education department. That gave it strength. That gave our education strength. कि world level पे हम पढ़ाते हैं. No question about that. हमारी education, हमारी pedagogy, हमारी assessment, all of this is at world level. That is why you got the accreditation also, sir. So उसी लिए we need to have PMDC recognize bioethics as a separate entity, a department. नहीं सिर्फ ये कि वो क्योंकि नेक सर्जन है या नेक डॉक्टर है तो वो नेकी सिखाएगा दूसरों को. It is an entity in itself. So what we require is a structured approach to develop bioethics as a department, as a discipline, because it's an inter and transdisciplinary approach. उसके साथ that will give it strength. You will then be teaching, you will be making guidelines, तो फिर हमारे physician के पास भी guidelines होंगे कि ये सही है और ये गलत है. Self regulation उसके बाद आती है. So you know you have a benchmark and your own community has created that benchmark. उसके साथ वो चलती है. एक आध CME इधर उधर या हम 4 घंटे पढ़ा लेते हैं किसी को डिप्लोमा भी 1 साल के दे दिया. That's not just enough. This has to be inculcated and it has to be internalized by our doctors. वो young doctor जो है वो आता है किसी भी यूनिवर्सिटी के अंदर कोई सेमिनार हो रहा होता है, वहाँ वो बैग पकड़ता है, उसके अंदर गिवअवेज उसको मिलते हैं और वो खुशी खुशी घर चला जाता है बगैर without any information, any knowledge or anything else. We require the institutions to then buy in. So एक तो institutional buy in की जरूरत है, that you have to enforce that. Yeah. तो अभी हमारे पास यहाँ इश्तिहार लगे होते फार्मा के, which would be wrong.
We will certainly come to that. So thank you for a very comprehensive response, and I really feel, and I want to acknowledge that actually, but let me now, since we have a bit of time, take the opportunity to take maybe 2 interventions from the floor. So if there's anyone who wants to ask any question from our, and please you keep your questions brief and to the point so that our panelists can respond. So they can start with you quickly. Ji.
Thank you very much for a very insightful talk, and this is quite a good learning experience for everyone here. I have 2 points. One, that these ethical practices are perhaps very important in the pharmaceutical sector particularly. One,
address your question to the panelists. It's not about a comment from you at this point. I'm saying, do you have...
my comment will involve this question too. Okay, I formulate in the form of a question. Yes. What good practices we are bringing in to regulate pharma sector in Pakistan so that multinationals do not leave Pakistan because of bad practices of our local pharmaceutical industry? Question 1. Question 2 is that this conflict of interest regulation which World Health Organization actually prescribes is that your regulatory bodies should not have industrial interference in it. How Pakistan, how you, our experts actually look at it that all regulations, either that is food or pharmaceutical or medical practice, it does not have intense industrial regulation, because now we see that in one instance, formula milk has been taken away from DRAP and given it to the food, which is a lax kind of regulation. Thank you very much.
Okay, thank you. I think the question you pointed to our colleague from Nishant. Just hold, I'll take another question.
So we have another question.
No, the question, the lady is being trying to say. But Mushtaq, if you can just bring it up.
Thank you. So I have a question from PPM, maybe Usman Wahid. As you said that there is a system in place to do the audits for the pharmaceutical companies. So is there any benchmarks to see, what exactly amount of, funds will be allocated for the giveaways or out of country travel? Another question is maybe from the whole panel, who actually from the regulators see those audits, which is done either by, their internal audits or external audit, but who makes sure that these are done for all the companies and comply as per their benchmarks? Over.
Let's take those two and then we'll have one more round of two more questions. So maybe you start, Sir Srikant.
So, thank you for your question. There's a procedure for control of pharmaceutical industry. First of all, you talk about leaving the multinational from the Pakistan. Actually, the multinational pharmaceuticals, they are merging. So, if we talk about the GSK, they have 3 pharmaceutical, now they GlaxoSmithKline, they converted into one. They have the issues of price increase. In 2024, the federal government issued an order, an SRO, and the price was decontrolled only for the non-essential medicines, and only the essentials are controlled. And if we talk about the pharmaceuticals, inspections, or their procedures, we have 2 procedures. One is an internal audit and the other is external audit. Internal audit is conducted by the pharmaceutical companies themselves, and external audit is conducted by the DRAP or any authority which is called upon for the export purpose. And under the Act, we conduct the audit of pharmaceutical companies biannual, 2 times in a year. We go through all the procedures, their manufacturing, their testing, their release procedures, and these companies are also inspected by the foreigners sometimes, like a company going to be applied for the WHO PQ. The officers from the inspectorate system from the WHO came in Pakistan, and they inspect all the companies and issue their reports, like PICS and EMA.
Okay, thank you. Question from Zaib to Usman Bahid Sabar about...
First, I'd also like to comment on this multinational departure issue. So if you look at the history of regulation in Pakistan, prior to the formation of DRAP, and it was the Ministry of Health, the regulations are very loose, but there was a lot of resistance from the industry, despite the fact that they were not so stringent. And the reason was that there was a lot of ad hocism in the way regulation was done. Today, DRAP is far more stringent than the Ministry of Health used to be, but application is across the board. And despite the fact that there's a lot more compliance that we have to do as companies, you will find a lot less noise coming from the companies also. We understand that we have a responsibility to fulfill. And one of the reasons, as Zishan Saab pointed out, for the departure of MNCs was not this compliance issue, it was primarily the fact that regulation was prohibitive, particularly price regulation across the board. It almost drove this industry bankrupt. Now that we are reversing course, there are a greater number of companies getting regulated, whether it's getting certified, whether it's PICS or WHO or other stringent authority certifications. That in itself is raising the overall standard of the sector. And ethics are very much a part of that regulatory framework. So in terms of, in response to your question, the internal audit process, of course, is kept within companies. What we are doing now through this committee within PPM is beginning to share those best practices. So all of us know as companies what good sort of compliance looks like. But at the same time, there is an external reporting requirement, which we report to DRAP every year, are promotional expenses. That's done regardless of whether you're a PPMA member or not. Any registered company has to report those expenses.
So there are 2 more questions. One is from Mushtaq Saab and then from Rina, and then I'll go back to you.
Thank you, sir. Thank you very much. My first question would be from DRAP again. you have DRAP के mandate में therapeutic goods in addition to pharmaceuticals, medical equipment, medical devices, kits, laboratory kits, or from a quality of care point of view and from, of course, ethical practices point of view, the quality of medical equipment and devices and kits is very important. Does the DRAP has a mechanism and capacity to develop standards, specifications, and regulate these items at this point in time? My second question would be from Honorable President PMDC. Sir, issue ये है medical education में कि there are in addition to PMDC and medical universities, there are a couple of other universities who are being granted charter by the Higher Education Commission to undertake courses related to medical field like BS Dermatology, BS Radiology, Doctor of Radiology. Does PMDC look into that issue also, because that is leading to malpractices, sort of, जो भी आप कहें कि quality compromise और सारी unethical practices. तीसरा सवाल ये है कि बड़े हो गए कितने सवाल कर रहे थे? I'm taking advantage of my class.
Thank you, Dr. Samin. My question is from Dr. Rizwan Taj. Dr. Taj, I want to know your opinion about the Code of Ethics. To my knowledge, and please correct me if I'm wrong, the last Code of Conduct that was devised by PMDC was of 2012. It is outdated and forgotten. In 2021, PMC approached me and we made a cross-provincial, high-level committee. Dr. Jaffrey chaired that committee, and we spent hundreds of man-hours to renew and review the Code of Conduct. And the last final copy is still on Dr. Jaffrey's laptop. It has not been taken up or implemented. So what about that? Are you doing anything about that?
Okay, so Professor Taj Sahab, we start with you.
You spoke about the BS degrees that the universities are offering, and you spoke about the bioethics certification or degrees or whatever. In any department, how they are not on the map of radar of PMDC registration. What happens is any degree, whether undergraduate or postgraduate, has to be registered with PMDC. And we have very strict criteria of how we look at things, how we send an inspection team, how we look at the criteria. And then there is a very complicated system through which the application is routed. So for postgraduate degrees such as a BS or whatever, we have two forum. One is the postgraduate degree forum where it is analyzed, and then the standard recognition committee. Both committees are very full of thorough professionals, and where required we invite specialists of that area to look into that. So if it's not registered with PMDC, we do not accept its validity for prescription or for practice. And one of our biggest headaches, just to share with you, is ethic care medicine. You know, at this time it's a hot topic, and we've made a very strong committee for specialist committee for that, and we are looking into that, and it is one of our biggest challenge areas at this time. Again, I think the positive thing is that medical education has flourished in the last 2 or 3 years. And the WFME inspector said that medical education in Pakistan is so well developed as compared to India that we are very happy about that. And it has really developed, and I've got a degree in medical health professional education, and every colleague is now enrolling in these programs, and I hope that bioethics will run the same path as well. So again, we are succeeding, and we will manage to get all processes followed.
Thanks very much. एक शब्द आपको सवाल, ड्रैप को हमेशा सबसे ज़्यादा सवाल, तो you will have.
Most welcome. Dr. talk about the standards and quality of the medical devices. We have the medical devices rule 2017. Under these rules, we allow for the registration or import of only those medical devices which are either CE mark or registered in the country of origin. Means that if you are going to import a medical device from any country, if that medical device is not registered and approved by that particular authority, we did not allow. And there are ISO standards for the medical devices.
Thank you. So I think there could be questions that you could do over coffee because we're going to have a coffee break. I want to move on because we just have a few minutes left. So you can certainly check with Professor Rizwan on the code of conduct. Later on, maybe you'll get a chance to respond to the code of conduct as well. I want to move on to something else because I think it's an important thing. And the question that I have for all the panelists, we've had a good conversation and a good discussion, is we all, and I know in this country, we tend to work very nicely independently, but not collectively. And we have PMDC, we have the DRAP, we have the PPMA, we have an academic institution, we have the council, healthcare commissions, and so on and so forth. Is there anybody from the Ministry of Regulation, Health Services Regulation Coordination here? Which is there. So, Janab, thank you for being here, sir. No, I'm not asking you to say anything. I'm just wanting to identify you. The point is the following. It's time for, if you want to make a difference to this, we have to learn to work collectively. And rather than just working in silos, I think we will just continue to work the way we have been working. So my question to all of you is, sir, starting again from you, is how can we do something collectively that we come together, not just in a forum organized by TI or London School, but ourselves? And what can the ministry and PMDC and others do to take the lead to come together in a forum?
I think all the different agencies and departments that are here and with the supervision oversight body of the Ministry of Health, our common goal is improving the healthcare of Pakistan and provide safe healthcare to the people of Pakistan. And for that, we all need to, and we do need to work together, and we need to have a forum where we discuss and we involve each other in our work, and we follow what is best for our country contextual issues, and we deal with them, and we progress on that line to bring relief to our population. So the common objective must never lose sight, and the ministry should give an oversight and strengthen all the bodies. So DRAP, us, other departments should be strengthened.
Collective working.
So yes, so collective working with so many different stakeholders are इसके अलावा भी हैं. So is a major challenge. Individually make a network, जिस तरह से ये भी बन रहा है, जिस तरह के ये बना हुआ है, and share. For instance, there are many guidelines.
What do you mean by individual network?
So connecting each other individually, I don't think that either DRAP nor PMDC nor CBAC will be able to take the lead. Yeah. So connect and share. So अभी जिस तरह से इनकी गाइडलाइन अभी इन्होंने मिशेल ने शेयर की थी, we would really like to put our intellectual input into that. You can share that with us also, and we can give that intellectual input into that also. So there are many guidelines, like Karachi Bioethics Group की गाइडलाइन मैंने वहाँ रखी हुई है for PPI, for Pharma Physician Interaction, 2008 से है. DRAP की guidelines हैं 2021 की, I believe, for focused on the industry, जिसकी हमने feedback भी दी थी. So these are all various parts of the elephant that we are palpating separately. There is room for. So there is room for coming together. Who will take the lead?
I will come to
That's
that.
the thing.
Ji sir.
Thank you. During the session, it was discussed that 40% of the doctors in the Sindh are using the medicine from the fictitious company.
Which represents almost the whole country. I don't want to put single out Sindh for that, to be honest.
If we talk about the collectivism, DRAP is issuing the drug alerts on daily basis on its website, and it's also on the social media as well. That clearly states that these drugs are declared either substandard, spurious, or adulterated. If any of the health professional, either doctor, pharmacist, or his colleague, just visit the website daily. He can go through that, what are the companies which are the fictitious and they are working.
सर वो ठीक है, अगर हम कोई ऐसा फोरम बनाएं तो उसमें ड्रैप would happily, willingly participate to. That's my question to you and of course to your CEO, because that is where I think we need to have collective thinking, Ji.
Yes.
So thank you for that response, sir.
जी, so I think एक तो जैसे Professor Jafri ने बोला, these convenings are very important, these individual convenings that like the one we have today, and my congratulations to Transparency International for bringing all the relevant stakeholders together. But I think where these efforts have been sustained and actually achieved impact are countries where actually formally structures have been created that are multi-stakeholder in nature. So जो भी अभी MCA की बात कर रहे थे, the Code Authority in South Africa, it actually has the medical societies, it has their equivalent of the PMDC, it has the pharma sector, all sitting in one authority that actually oversees and collectively governs the effective implementation of these. One thing I would want to raise, we have to be aware of the context that we're in. Pakistan is a country that spends less than 1% of its GDP on health. So that means that we also have a resource problem, right? Uni resources ke andar, there is a very positive role that pharma plays in terms of CME dissemination across the country. Sure. You know, Michelle said there is an overdependence on pharma sector, which is absolutely true. But in the absence of this, we cannot expect a government that has such resource constraints to be able to effectively get involved in all these areas, which is why we have to all step up and play a role. But a formal structure where there's DRAP, where there's the other bodies, where there's the pharmaceutical sector will definitely.
Thank you. Keep in mind that Pakistan is a heavily devolved country, and without engagement, and I don't see any provincial drug authority here, which I think they should have been here as well, I think we will not be able to meet our ambitious challenge that we are supposed. Ministry of Health se sir koi maujud the? Sir, you have 1 minute to make your, are you in a position, is the ministry in a position to take the lead, mere sawal ye hai, to take the lead to bring all these stakeholders together and come up with a forum where these issues could be discussed beyond a seminar like this. इस पे सर अगर आप जवाब देंगे तो बड़ी मेहरबानी।
अस्सलाम वालेकुम। इसका जवाब सर अगर आप देखें तो ये मैं शुरू करता हूँ लेफ्ट से, सी और ड्राइव बैठे हैं, सुने ना सर मिनिस्ट्री है ना, आई एम टॉकिंग अबाउट मिनिस्ट्री, हियर इज एन अम्ब्रेला, दे आर डिफरेंट विंग्स।
आप ऑटोनोमस है क्या नहीं है सर?
नहीं सर, मिनिस्ट्री के हैं, मिनिस्ट्री के हैं।
ये नहीं, मिनिस्ट्री ऑफ हेल्थ, सेक्रेटरी, डीजी एंड मिनिस्टर, मैं इनसे पूछ रहा हूँ क्या ये जवाब देना चाह रही है?
अच्छा, ये क्या? नहीं बताइए सर।
जी सर, इनको
देखिए डॉक्टर साहब, सबसे पहले तो ये कि वेयर देयर इज अ विल देयर इज अ वे।
करेक्ट।
और अभी टाइम है, हमने पहले टाइम ज़ाय किया है सोच के कब करेंगे, अभी ये टाइम है कि हमें स्टेप्स लेने हैं। अगर आप ये कह रहे हैं कि ये हमारे पार्ट्स नहीं हैं तो दे आर वेरी गुड आर पार्ट्स, 1 से लेकर 4 तक ये जो इनकी कमिटमेंट यहाँ पे शो हो रही है ना सर, सी और ड्राइव भी हैं, साथ में HS से बैठे हैं, हमारे पास फार्मेसी बैठी है, सुने ना, ये सब वो हैं जो हमारे लिए गाइडलाइंस भी हैं और फ्यूचर भी हैं। बाकी रही बात मिनिस्ट्री की, इंशाल्लाह सून यू विल सी अ गुड न्यूज़ फ्रॉम द मिनिस्ट्री एज वेल, बिकॉज मिनिस्ट्री इज टेकिंग सो मैनी स्टेप्स, इट इज़ अर्ली टू डिस्क्लोज दैम. But you will get fruit, inshallah.
Inshallah. So thank you very much for that. I think, 30 seconds.
I just wanted to inform the forum that we already have started. There is a combined regulatory forum. We have had our formal meetings, and it's continuing in each quarter. And Dr. Mushtaq hosted it in Punjab in February, and next we will be hosting in Sindh.
Thank you. Ji sir,
you have given opportunity to your class fellow, give to your student as well. Thank you very much. A very smart question to the point that regarding the whistleblowing role of the regulatory authority like PMDC. What we observe that there is a law in Pakistan for protection of breastfeeding. And that law is in place. Guidelines are there, procedures are there. But there is a violation. For example, in the recent floods, at the top level, there was a violation. The statement was given for promotion of formula milks to the people. And similarly, the practices are going on, promoting the formula milk in the hospital, giving the samples. So the whistleblowing role is that not only to react, but also to keep educating the people that this is the law already in place and how people can actually report, how people can raise their voices, and then issue warnings, for example, in case of violations, like the PEMRA does in Pakistan, the Pakistan Regulatory Authority.
Thank you very much. So we're going to come to the close of the panel, and I'm just going to, of course, thank the panelists, but I'm going to close by, I don't want to put you on the spot, but I want to say, in the next 12 months, each of us, what can we do, starting, sir, with you, to be able to make a difference to improving ethical practices in the health sector in Pakistan? So what could you do in the next 6 to 12 months?
So I think this is an open call from us as an industry. We have now decided to take collective action. We have expressed our interest in partnering with PMDC, with CBEC, with the Health Services Academy. Let's start actually rolling out awareness sessions across the country, at medical colleges, at medical society meetings, at all the relevant points where the medical community convenes.
Thank you very much. I think that's a great start.
Thank you. There's need to conduct the seminars on the ethical practices and coordination between the DRAP and PMDC, doctors, and rest of the organization.
And DRAP will take the lead on doing the seminar?
Sure.
CEO sahab baithe hain. Theek hai, sir? Okay. Absolutely. Wonderful. Done. Thank you for that. I think it's not just one, we need maybe many seminars, but it's a good way to start. Thank you. Very good.
So in the 6 months starting today, do something that we've been trying to do for the past 20 years, get closer to the PMDC. And yes, exactly. So this is a fantastic forum, and to see how bioethics can be recognized as an entity in itself, so that institutions have departments of bioethics as they have departments of medical education, so that we churn out not just medical educations and practitioners, but also ethical practitioners, which will help us in developing all these guidelines, etc., etc. So I think this connection would be my take home from this.
Okay, thank you. Last
I think it's just two areas which are very much doable and will happen in the next 1 year. One, I've already mentioned the CME, is continuous professional development, which will be mandatory to have the ethics as part of the hours of education that they will undergo. And number two is the medical colleges curriculum, where we have inculcated bioethics, and we want to make sure that the ethics is taught, and the ethics is and we have a good number of trainers to teach bioethics. At the moment we don't, but I think it's just like medical education. Within a couple of years, there will be numerous people who will have trained in bioethics, and they will be able to impart that to the students. Thank you.
Thank you. So great points for action. So with that, I don't want to summarize this. I just want to, if I were to take one message, I would suggest that we need to now establish a collective forum whereby, under the leadership of the Ministry of Health, National Health Services, and I want to emphasize the word regulation and coordination, we should bring a forum together where many stakeholders can come and not only discuss but develop a roadmap for addressing these problems. And thank you, sir, for your presence. With that, I think I want to thank the distinguished panel. We had an amazing panel conversation and discussion, and I think they deserve a hand, so I really want to acknowledge for this. And we will close the session now. Thank you very much for this.
Thank you to our moderator and panelist for this insightful dialogue. We will now take a short break for tea and networking. The tea is set up at the left side of the hall, so please be back after 15 minutes. Thank you, everyone.
follow करते रहोगे, लेकिन बाद में
मैं मिस कॉल देता हूँ मैंने कहा कि 50 साल तो आईसीटी के ऊपर पहुँच गए हम लोग IMS पहुँच गए हम लोग एक्चुअली IMS क्या बात नहीं यार 1980 में गया था मैं डाउन मेडिकल कॉलेज में ज्वाइन किया उसके बाद से मैं आई मीन याद कभी थिंक करते रहे सही था बट नाउ दिस इज एक्सीलेंट
I would request everyone to be on their seats. We will going to start our next session. Hello everyone. Dear everyone, I would like to request you, please return to your seat. We are going to start.
Maybe can we request everyone to please take your seats so we can start?
नहीं करेंगे
Welcome back, everyone. Let's move towards our next session. Welcome back, everyone. Let's move towards our next session, which is consist of a panel discussion. Our second panel will focus on strengthening regulations and their implementations, moderated by Mr. Kashif Ali, Executive Director of TI Pakistan. Our panelists are Dr. Noor Mohammad Shah, Director Licensing. It's happening something. Yes, Director Licensing at DREP and in charge of the API cell with 33 years of experience in drug administration. He has served across multiple divisions. He also drafted the Internationally Harmonized Medical Devices Rules 2015, initiated the enlistment of alternative medicines, and assisted in drafting the DREP. Dr. Zainab Hassan, Director of Clinical Governance and Training at SHCC, bringing expertise in regulatory oversight, training and governance reforms in health services. Dr. Ms. Aisha Tamehak, Executive Director of Pharma Bureau, representative multinational pharmaceutical companies in Pakistan and a leading advocate for ethical industry. Dr. Shehzad Ali Khan, Vice Chancellor of Health Service Academy, specialization in health system, strengthening capacity development and evidence-based policy making. I now invite Mr. Kashif Ali to lead the session.
Okay. So thank you everyone for joining the second panel discussion. I think it's very difficult to meet the energy of Dr. Samin, but I'll try to give my best. And I think also I was wondering that a lot of points that we were potentially were aiming to cover in this session were also discussed in some primary sense during the previous session as well. But just to quickly introduce the panelists and also the structure. So the structure that we are going to follow is there'll be one key question from each of the panelists, and every one of you will have 7 minutes to respond, and then we'll open the floor to the audience for 10 minutes to get your questions, and finally we'll go to the panelists for their final reflections. Now, as my colleague Raima mentioned, so we're joined by Dr. Noor Mohammad Shah, who's the Director of Licensing Board at DRAP. We're joined by Dr. Zainab Hassan. She's a Director of Clinical Governance and Training at the Sindh Healthcare Commission. Ms. Aisha Tamehak, President of Pharma Bureau, and also Dr. Shehzad Ali Khan, the Vice Chancellor of Health Services Academy. So maybe, Dr. Noor Sahab, if I can come to you, as part of the, being the long-term association with the DRAB, you have been involved in also designing the medical devices rules. So I think one key point that we have seen since the morning is around the capacity constraints or the capacity needs of the DRAB. In your opinion, what specific reforms are needed for DRAB to sort of perform its oversight role more effectively, and also if you can identify some of the key areas where this capacity constraint remains? Thank you.
Bismillahirrahmanirrahim. The Drug Regulatory Authority Pakistan, established under the Drug Regulatory Authority Pakistan Act in 2012, the purpose of its establishment was and is to provide safe and effective therapeutic goods to the people of Pakistan. So DRAB has tried its best to perform its function in the best way. However, improvements are always needed for further progress in the field, and DRAB is doing so. Recently, as my colleague stated, that all the systems of the DRAB have been made online. There is no now physical contact and documents, physical submission of the documents. This is a great achievement. Secondly, DRAB is working on the global benchmarking to get level 3, and inshallah, very soon you will hear that that achievement will be obtained. Yes, there are some constraints. The main is the resources, human resources. So if resources are available, then inshallah we can go forward in a better way. Because under the Constitution of Pakistan, the subject of drugs and medicines were then only the matter of the provinces, but the provinces under Article 144 of the resolution of the Constitution authorized the DRAB constituted under the Act to perform the functions of the regulation of the drugs and medicines, along with medical devices and alternative medicines, medicated cosmetics, and other health products. So the scope was very much increased. The health and OTC products field is much bigger than the drugs and medicines, and similar is the case of medical devices. My concept was, when I was framing the medical devices rules, so there was a point, and our aim was to establish a separate independent medical device authority, as there in so many countries, including Malaysia. So, yes, there is a constraint of resources. The main constraint for we is the shortage of resources. We have tried to hire more and more people, but some constraints are there. The second one is the training of the personnel, technical personnel. That practice has been initiated, and under our new CEO, Dr. Obaidullah Saab, many workshops and seminars have been held, and inshallah, in that subject, we will achieve more. So these are some points to be discussed and stated as I told.
Okay, and I think we'll come back to some points that you mentioned. Dr. Zainab, सुबह से मेरे ख्याल जो डिस्कशन थी उसमें एक चीज़ जो मैंने भी ऑब्जर्व की वो ये है कि clarity on the role of the regulators. And I would like to ask you if you can walk us through what is the role of Sindh Healthcare Commission and the provincial regulatory authorities when it comes to detecting and also identifying these malpractices. And secondly, also, if there is a malpractice, what actions can the Healthcare Commission in particularly take? And if you can also comment, what sort of collaborations are needed to sort of strengthen this oversight function at the provincial level.
Thank you so much, Kashif. So it's not just in the Healthcare Commission. I think this is the similarity across all the commissions in all the provinces. Punjab is ahead of us, and then it is the Sindh Healthcare Commission, and the other commissions are also established now. Balochistan is started, and inshallah soon we will have the GB Commission, and there is IHRA. So almost all of us have a similar act, so the similar working. So I will use the Sindh Healthcare Commission domains to explain how every commission is actually working. So basically, we are regulating the health service delivery. And while we regulate the health service delivery, we have many operational directorates. इसके अंदर से पहली चीज़ है to license a health facility for service delivery. तो per se, we are not looking at the training of the healthcare providers individually, because that is the domain of PMDC and other councils. But we are looking at the HR within the facility and how well they are trained and how they are delivering. Even if it's a single clinic, then how well the GP is trained and how well they are delivering. To establish all this working and the licensing, the first thing that comes is the quality standards that we have established. We are called the minimum service delivery standards. So all of these standards are developed with the idea of patient safety and to prevent medical errors and to prevent patient harm. That is the core direction of the standards. So we have, within the prescribing sections, we have such things such as the prescriptions should reflect ethical practices and the rationale prescribing, for example, and also that it reflects good current best practices and it is no overprescription done, and the patient rights are not violated. Another key factor in the standards is the informed consent. That is a very, very important component that we very critically look at. And then there is no commercial bias in the facilities, and this means whether it is subliminal, whether it is implicit or explicit, but this commercial bias that we are talking about over here, pharmaceutical के बड़े-बड़े इश्तिहार लगे हुए हों वहाँ पर, या things that are sponsored by pharmaceuticals are really taking the front line, that is something that we carefully look at through our standards. So we have a licensing directorate, and during the inspection, all of these standards are looked at, and a CAPA, which is a corrective and preventive action plan, is given, and so it is it is our effort to try to contain any of these malpractice and ethical issues. Then after the licensing, there is a monitoring and evaluation directorates that continuously over a period of 5 years, they are continually going to monitor the KPIs. So a few of the KPIs also include how many complaints were there, how many malpractices were seen, and so they monitor all of those things. Apart from that, then we have the anti-quackery directorate. These are the people who are going to go catch all those people who are not qualified to do. And when we look at the trained professionals and them prescribing all these medications or over-prescribing, many and really a lot of them are actually quacks because they're not even trained. So their best practice is to give an over-prescription of pain medication and a bolus of steroids and a lot of IV drugs and straighten out the patient. Patient goes home happy if he's fixed in a day. But majority of these practices, yes, there would be trained GPs and physicians doing some of it, but please be aware that there is a huge bunch of this activity going on within the quackeries culture. So quackery is something that is becoming a big problem for us, and that's also an arena we have to look at, because they are the ones who are overprescribing, and physician sometimes is at an odd because the quack next door is treating the patient with an injectable where it is not required, and so they have their own issues as well. So then we have a complaints directorate. So when there is a malpractice, we have a very established complaint management system where there is a proper hearing done. And as Vakar Bhattisa was asking, who decides, then we have a whole panel of experts who sits there and evaluates the files, the prescriptions, all the paperwork. And then there is the decision whether something was done in good faith or whether it was a malpractice or something is oversight over there. And majority of our complaints, when we were talking about disclosure, the number of complaints that we do, it is available on our website. But the types of complaints that so far we get is not really about some doctor has overprescribed a medication to me or overprescribed costly tests to me. This is not the way the people are complaining yet. So we also need a lot of public awareness on such things to bring into complaints from about doctors who are doing that, so they can actually be looked into from this ethical point of view. Right now the complaints are about patient getting hurt, most of that about that. So that's one thing. Then at Sindh Healthcare Commission, we are also big advocate for ethical practice, and we are open to a lot of research in this area, and we collaborated with Dr. Mishal and her team on this landmark study, and it was a lot of eye-opener for us as well. We really enjoyed working with the team and learning about all the drivers for the GPs, why they would be prescribing in this way. And it was a lot of learning, really. It was an excellent experience. But you see, the commission alone, we have a very specific domain. Just healthcare commissions alone won't be able to do it. And again, just as we have talked about in the morning, that we need all the regulators. So there will be DRAP doing something and the pharmaceutical industry doing something and us doing something, and on one page. And we do have recently established this year a combined regulators forum. And these are the kind of discussions I think that we could put on agenda of our combined forum, where DRAP also sits, PMDC and councils also sit, we also sit, and we can all talk about this and have a unified framework with very specific goals for all of us, similar goals, because in the end it's the patient that we want to save. Whether the DRAP does something or we do something or the PMDC does it, in the end all we want is safe patient care. So I think that is where the way to go.
Thank you, Dr. Zainab. Ms. Aisha, you represent a Pharma Bureau which also comprises of many MNCs. So how does, because when we are talking about the gaps within the existing regulations, how does the industry see current regulations? And what, in your opinion, could be some specific reforms to improve the functioning of the regulations? So, for example, we know that there is a rule on reporting of marketing expenses, but then only few companies do that. So how do we strengthen this existing regulations and the reporting around this?
Thank you, Kashif, and thank you for inviting me to this. It's been quite enlightening. I represent the multinational pharmaceutical companies who operate in Pakistan. We used to be 48, and we're down to nothing now. I think there's about 18 companies left. There are only 2 in manufacturing. The rest have exited. And I'd like to make a little point here before I get to your question, because somebody asked that question about multinationals leaving. And it was largely to do with the fact that there was no consistency in policy. And as recently as a month ago, a multinational company has closed its doors in Pakistan and left. So I think what we are looking at now is a huge change. So I will first go to the positives. And the positives are that DRAP has really stepped up. And they are doing a lot of very good work. There's a long way to go. I know human resource is a huge problem for them, but they are making huge efforts to achieve PIC certifications, etc. Because until the regulator is certified, there's not very much else the industry can do. You need to have a certified regulator. Our main issue in Pakistan has been an uneven playing field. because MNCs, I know they have nobody likes them, and I know that everybody says big pharma is terrible, and but the fact is that they're the people who do the research, they're the people who spend the money, they're the people who bring innovation. So we really need to keep them here. We need to keep innovation coming to Pakistan. We need to make it easier for innovation to come to Pakistan. At the moment, no company wants to bring a new drug because there's no IPR protection. So you, as a Pakistani, you are missing out on breakthrough treatments, and the only people who are suffering are the patients. We are talking here about patient access, patient safety, patient, what's good for the patient. Well, it's not good for the patient not to get a brand new drug. They have a right to get it. So, and I've seen now that the processes at DRAP are faster. But there are lots of issues that remain, and we need to strengthen them. So the number one issue for us is that there has to be a fair playing field. The other thing is that when we look at the problems that we're talking about today, which is ethical marketing, if you look at the issues that brings with it, all you have to do is to go out into the market and you can see where the money is being spent, what the disproportionate spending is, who's doing it. It's not hard. Anyone can go out and see it. The figures are staggering. But again, unless you have the resources to go out and monitor, not much is going to happen. So we really need DRAP to strengthen its monitoring facilities. They need to be able to make sure that everybody is logged in on their website. The 10% limit that has been imposed on ethical marketing should be followed by all companies. We absolutely agree with that. In fact, the Pharma Bureau, as early as 2016, drafted an ethical code and sent it to DRAP and said, here's something that we have come up with. Why don't you get everybody to debate this, talk about it, and maybe even implement it? Subsequently, DRAP did come out with its ethical marketing rules, but they're nowhere as stringent as the rules that MNCs adhere to, because they follow the International Federation of Pharmaceutical Manufacturers Association code, so which is far more stringent. So I think that what we really need to look at is something that you're trying to do here, and that is to get everyone to collaborate, because there is a huge trust deficit. Nobody trusts what the other person says or does. And to me, that's the biggest problem. Because unless we can all sit down together, have a conversation, a real conversation, and say, look, these are the problems, this is the impact. Yes, you are a company, you need to make money. Yes, you're a doctor, you have the right to get a fair fee, etc., etc. But you can't have doctors taking incentives to prescribe. Should doctors be running pharmacies? Pharmaceutical companies are there to make profits. They're not there as, they're not philanthropists, unfortunately, for all of us. But they are there to make profits, because those profits are then plowed back into research. So we need to come to some kind of an understanding of what everyone's role is, and then temper those roles, okay? You don't need to make 10,000% profit. But you need to make enough profit that you can run your company, you can carry out research. We have no research in Pakistan. We have this fund called the Federal Research Fund, which has been set up under the 1976 Drug Act. The money has never been used for research. Nobody knows where it is or what it is. It is not the DRAP's responsibility. It's nobody, we just don't know what happens with that money. And that should go into research. Now, you cannot have the government doing the research. Research is for academic institutions and pharmaceutical companies collaborating. So what we are looking at now is cut this fund and have companies doing research. That's the only way Pakistan will maybe catch up with a country like India. They do their own research, and they've been hugely successful. They have many patented products. We have absolutely zero in Pakistan. So there's a lot of things that we need to do, and I'm very happy that you're doing this seminar. This is the second seminar that I have come to, and I feel that it's really, the theme has developed and grown, and hopefully the next one will pick up on some of the issues that are raised here and will develop and grow as well. But I truly believe that dialogue is the most important thing, and without that, we will not talk to, if we don't talk to each other, we can't trust each other, we can't trust each other, we can't work together.
Thank you very much, Ms. Aisha. I think many pertinent points. On the fund, I think one of the recommendations that we have also given is for the TRAP to also annually publish, the update on how much spending has been done around that fund. And you're right. I mean, in terms of the availability of information, where that money is going, how is it being utilized, is absolutely also essential. But just to pick up from where you left on the public trust. Dr. Shahzad, if I can turn to you, some of the surveys that we have also done at TI shows that the public trust in the healthcare sector is very weak. And just to give you an example of the 2023 survey that we published, many citizens perceive healthcare as a least transparent sector. And again, what Ms. Aisha said, one of the the potential cause could be this absence of data on the enforcement and also on the implementation of regulations. So my question to you is, in your opinion, and also as a leading HSA from your research background, what are some of the challenges, the governance challenges for the healthcare sector, and what reforms would you propose?
Thank you. Bismillahirrahmanirrahim. Assalamu alaikum. I'm lucky that our honorable chairman of the standing committee, Mahesh Malani Sahab, has joined. It will be a good so that our voice reaches to the relevant sessions over there. थोड़ा सा मैं आपको एक अपना बता दूं कि इस वक्त I am not representing, मुझे किसी ने इन्वॉल्व करने की कोशिश की थी मिनिस्ट्री के बंदे ने कि जी ये हमारी मिनिस्ट्री बैठी है. I am here as an individual capacity, तो जो मैं कहूँगा वो मिनिस्ट्री का ऑफिशियल वर्जन नहीं होगा, मेरी HSA का होगा, मेरा ज़ाती हो सकता है, लेकिन मिनिस्ट्री का फिर मिनिस्ट्री से आप पूछेंगे कि उनका क्या वर्जन है इसके ऊपर. सबसे पहली बात तो ये है कि वी शुड रिकॉग्नाइज दैट हेल्थ इज नॉट लाइक एनी अदर सेक्टर. पहला जो सबसे थंब रूल है वो आप सब जहन में रखें कि ट्रांसपेरेंसी इंटरनेशनल हो या पॉलिटिशियन हो या ब्यूरोक्रेट हो, वो ये मत समझे कि एनी अदर कंज्यूमर सेक्टर इज सेम एज हेल्थ सेक्टर. हेल्थ इज यूनिक. Why? Because हेल्थ सेक्टर का जो कंज्यूमर है वो पेन में होता है, एगनी में होता है, सफरिंग में होता है, हॉस्पिटल में होता है, तो उसको कोई होश नहीं होता. आप उसको जाके परसेप्शन जब उसकी लोगे, कोई पूछोगे उससे सवाल, तो वो कंप्लेंट ही करेगा. So a normal consumer will not be in the hospital. He or she will be in agony, pain, suffering. माँ बीमार है, बेटी बीमार है, मियाँ उसका दाखिल है, बच्चा दाखिल है. So he will be stressful, he will be anxious. So don't think that it is any other consumer market. It is a very different market. This is one bottom line which you should note when you are starting to develop any survey. कि आपने एक मार्केट में जाके सवाल पूछ लिया और एक अस्पताल में जाके सवाल पूछ लिया, ये गलत है. Number 2, government alone cannot provide services to the population. I think अगर आपने नॉर्मल सी एक प्राइमरी केयर और सेकेंडरी केयर की एसेंशियल चीजें देनी हो ना, तो एसेंशियल सर्विसेज भी देनी हो, government alone will never be able to provide at its own. You will need the private sector contribution and you will need the partnership. Government alone दुनिया की नहीं कर सकती, except GCC. I think न्याई साहब को पता है GCC can afford I think anything. गल्फ जो कॉर्पोरेशन काउंसिल है, इवन USA, यूरोप, किसी किस्म का जो मुल्क है ना, वो ये नारा नहीं मार सकता कि हम फ्री सर्विसेज देंगे. मलानी साहब प्लीज आपने वापस जाके पॉलिटिशियंस को समझाना है कि फ्री हेल्थ सर्विसेज का नारा मारना प्लीज छोड़ दें. इससे बड़ा झूठ नहीं है कि आप लोगों को ये कहें कि सरकारी अस्पतालों में सब कुछ फ्री मिलेगा. नहीं मिल सकता. अगर आपने छापे मार के अस्पतालों के अंदर डॉक्टरों को, एडमिनिस्ट्रेटर्स को और वहां पे काम करने वाले लोगों को हरास किया और उन्हें ये कहा कि आपने नहीं किसी को चीज बाहर से मंगानी, तो फिर द गवर्नमेंट हॉस्पिटल विल प्रोवाइड ओनली दैट थिंग विच इज अवेलेबल. in the hospital, not what is needed by the patient. जब आप जबरदस्ती कहेंगे ना किसी को कि आपने अस्पताल से बाहर कुछ नहीं मंगवाना, तो जो अस्पताल में 4-6 गोलियां दवाइयां पड़ी हैं, हर पेशेंट को वही मिलेंगी, जो जरूरत है वो नहीं मिलेगी. ठीक हो गया? ये चीजें बेस लाइन है. सर्विस डिलीवरी में अगर गवर्नमेंट का रोल होता तो अमेरिका में भी सर्विस डिलीवरी गवर्नमेंट कर रहा होता, यूरोप में भी गवर्नमेंट कर रही होती. नहीं है. एनएचएस भी प्राइवेट के साथ काम करता है, सेक्रेटेड गवर्नमेंट हॉस्पिटल्स होते हैं. इसके अलावा सर आप ये देखें, गवर्नमेंट का क्या काम है? आपका जो सवाल था, वेरी सिंपल. गवर्नमेंट का काम है, सबसे पहला फंक्शन गवर्नमेंट का यही है जिसके लिए हम आज बैठे हुए हैं, गवर्नेंस, स्टीवर्डशिप. उसको स्टीवर्डशिप कहते हैं, गवर्नेंस कहते हैं. गवर्नेंस इज नॉट visiting the government hospital and harassing the people working there and serving to the patients. और वहां पे तस्वीरें बनवा के, खिंचवा के, गालियां दे के डॉक्टर्स को, नर्सेस को, पैरामेडिक्स को, ये गवर्नेंस नहीं है. गवर्नेंस का एक पूरा तरीकाकार होता है, अकाउंटेबिलिटी का तरीकाकार है, ट्रांसपेरेंसी का तरीकाकार है. ये पॉलिटिकल शो तो हो सकता है, बट इट इज नॉट गोइंग टू इंप्रूव एनीथिंग, बल्कि ये इट विल हर्ट द सिस्टम बैडली. जो लोग थोड़ा बहुत सरकार में काम करना चाहते हैं वो भी नहीं करेंगे काम, अच्छे लोग छोड़ जाएंगे. प्राइवेट सेक्टर में बड़ी मार्केट अवेलेबल है. सो हमें देखना है गवर्नमेंट में गवर्नेंस कैसे होगी. गवर्नमेंट में गवर्नेंस होती है पॉलिसी मेकिंग से. गवर्नमेंट में गवर्नेंस अपनी करा सकती है ट्रांसपेरेंसी, अकाउंटेबिलिटी के सिस्टम डेवलप करने से. आपने कहा फार्मा डॉक्टर नेक्सस है या डिफरेंट किस्म के करप्शन हो रही है. करप्शन इज वेरी सिस्टमैटिक. जब करप्शन होती है ना, बड़ी सिस्टमैटिक होती है. तो हमने फिर हेल्थ के अंदर गवर्नमेंट सेक्टर को भी सिस्टमैटिक तरीके से मैनेज करना पड़ेगा इस करप्शन को, इस नेक्सस को. तो आपने ये जो विजिट्स हैं, इसकी बजाय अगर आप उनसे पूछें जिनके पास पावर है, देखिए एक एमएस है हॉस्पिटल का या एक प्रोफेसर है, उसके पास कोई एडमिनिस्ट्रेटिव और फाइनेंशियल पावर नहीं है टू परचेज एनीथिंग. वो होता है ब्यूरोक्रेसी या टेक्नोक्रेसी, या डीजी हेल्थ करता है या सेक्रेटरी हेल्थ करता है. आपने छापा मारा अस्पताल में, अस्पताल अगर खराब है, उसमें प्रॉब्लम आई, शिकायतें आई, सेक्रेटरी को क्यों नहीं सस्पेंड करते, डीजी को क्यों नहीं सस्पेंड करते, जिसकी अल्टीमेट रिस्पॉन्सिबिलिटी है. हमने सर परफॉर्मेंस बेस्ड इंसेंटिव्स. अब मैं आता हूं सॉल्यूशंस की तरफ. वी नीड, सबसे पहली बात, जो अगर गवर्नमेंट सेक्टर है ना हमारा बदनाम है, आपने बिल्कुल सही कहा, द परसेप्शन ऑफ अ गवर्नमेंट हॉस्पिटल इज ऑफ पुअर क्वालिटी. व्हाई? बिकॉज यू आर फोर्स्ड टू गिव द पेशेंट विच इज अवेलेबल, और कुछ नहीं. तो जो भी अवेलेबल है वो देंगे, और वो यूजुअली उनका तरीकाकार भी ठीक नहीं होगा डॉक्टर्स का. क्योंकि एक चीज याद रखें, पाकिस्तान में सबसे बड़ा गवर्नमेंट सेक्टर के फेलियर का एक रीजन ये भी है कि देयर इज, मरानी साहब, देयर इज नो प्योर प्राइवेट sector in Pakistan. I don't believe that there is a private sector in Pakistan in health sector. The government sector of the morning is the private sector of the evening. चेक कर लें आप किसी भी जगह पे. सरकार का प्रोफेसर है, सुबह सरकारी अस्पताल का कंसल्टेंट है, शाम को अपने क्लिनिक में बैठा हुआ है. ये दुनिया में कहीं नहीं होता, सिर्फ पाकिस्तान में हो रहा है. इट इज इम्पॉसिबल कि आप ठीक कर सके चीजों को. वही प्रोफेसर अपना अस्पताल चलाएगा शाम को, या अपना डिपार्टमेंट सेट करेगा. ना सर्जरी होगी, ना सीटी स्कैन होगा, ना एमआरआई होगा. सो देयर इज नो प्योर प्राइवेट सेक्टर. इट इज मून लाइटिंग. द मून लाइटिंग इज एट द हाईएस्ट लेवल. दुनिया के किसी मुल्क में सरकारी डॉक्टर को अपना सेटअप करने की जरूरत नहीं होती. आपको पूछना पड़ता है कि आपने या ये करना है या ये करना है. ठीक है, उसको भी हमने खत्म करना है किसी तरीके से, तब हालात बेहतर होंगे. इसके अलावा आप देखें, पब्लिक प्राइवेट पार्टनरशिप हमने सिंध में ट्राई की, एनपीपीआई बेहतरीन मॉडल था. इवैल्यूएशन की, मैंने भी इवैल्यूएशन की, बेहतरीन रिजल्ट थे. पीपीएचआई बेहतरीन रिजल्ट थे. अभी केपी कर रहा है, पंजाब ने करना शुरू कर दिया. सो द फ्यूचर इज पब्लिक प्राइवेट पार्टनरशिप वेयर यू कैन डू इनोवेशन, वेयर यू कैन डू सम, चेक रख सकते हैं आप इसको. परफॉर्मेंस बेस्ड इंसेंटिव रखें, पीरियड बेस्ड अपॉइंटमेंट्स करें. आप टाइम दें 3 साल का. और केपीआई आपने अस्पताल वालों के क्यों रखे हुए हैं? केपीआई वाले गवर्नमेंट के सेक्रेटरी के, डीजी के केपीआई रखें ना, कि तुम्हें 2 साल के लिए सेक्रेटरी लगा रहे हैं, नहीं चेंज करेंगे, 2 साल के बाद ये इंपैक्ट तुम लेके आओगे, नहीं आओगे तो आपको हटा देंगे. सो जो हाईएस्ट लेवल का मुझे वीसी लगाया ना, मेरा केपीआई होना चाहिए कि आपकी यूनिवर्सिटी अभी इस तरह है, आपको 3 साल के लिए लगा रहे हैं, 3 साल के बाद तो 6 महीने के बाद रिव्यू करेंगे, अगर नहीं है यू विल बी रिमूव्ड. सो परफॉर्मेंस बेस्ड इंसेंटिव रखें, पीरियड टाइम बेस्ड उनकी पोस्टिंग करें. ये नहीं है कि 2 महीने के बाद, 3 महीने के बाद आप उनको ट्रांसफर कर देते हैं. तो जो हमारा फ्यूचर है, दैट इज पब्लिक प्राइवेट पार्टनरशिप, आउटसोर्सिंग. इट्स अ मिक्स ऑफ दोस थिंग्स. गवर्नेंस को इंप्रूव करने के लिए हमें स्टैंडर्डाइजेशन करनी पड़ेगी, स्टैंडर्ड सेटिंग, पॉलिसी मेकिंग, ये सब चीजें. देखिए, जब गवर्नमेंट सर्विस डिलीवरी में इन्वॉल्व होती है ना, तो वो अपने असल फंक्शन छोड़ देती है. जब आप सर्विस डिलीवरी में इन्वॉल्व होंगे ना, तो फिर तो पीएन की ट्रांसफर भी आपने करनी है, फिर तो सेक्रेटरी के पास एमओ की ट्रांसफर भी जा रही है. इतना ऑपरेशनल वर्क होगा सेक्रेटरी के पास, ही विल नॉट बी एबल टू डू एनी स्ट्रेटेजिक वर्क. सो लेट्स डिवॉल्व टू द डिस्ट्रिक्ट लेवल. लास्ट पॉइंट सर, आपने कहा फेडरल से प्रोविंस में डिवॉल्व कर दिया. प्रोविंस में कौन सी सर्विस डिलीवरी होती है? सर्विस डिलीवरी इज एट द डिस्ट्रिक्ट लेवल. सो व्हाई यू आर नॉट डिवॉल्विंग द प्रोविंशियल पावर्स टू द डिस्ट्रिक्ट्स, जहां पे डिस्ट्रिक्ट हेल्थ सिस्टम को एस्टेब्लिश करें. हम 20 साल से डिस्ट्रिक्ट सिस्टम के लिए प्रमोट करने करने की बातें कर रहे हैं एकेडमिशियन, WHO भी कहता है, वर्ल्ड बैंक भी कहता है, देयर इज नो डिस्ट्रिक्ट हेल्थ सिस्टम देयर, सब कुछ प्रोविंस ने अपने पास रखा हुआ है। तो प्रोविंशियल अथॉरिटी डिस्ट्रिक्ट अथॉरिटी को ट्रांसफर करे, उनको ऑटोनमस करे, तो आई थिंक द पेशेंट का फायदा वहां पे होगा। जी, थैंक यू।
Thank you, Dr. Shahad. I think maybe we can open the forum for 10 minutes for the reflection from the audience. Ji, sir. If I see any of my class fellow, I'll follow the Dr. Samin's.
So it's a class fellow day.
डॉक्टर शहजाद से क्वेश्चन है, कोई भी जो रेगुलेटरी इन्वायरमेंट है उसको किसी तरीके से जो कंज्यूमर्स या पेशेंट्स ये टेस्ट करते हैं थ्रू क्लास एक्शन, और क्लास एक्शन के लिए जो ओवरआर्किंग जो राइट है वो राइट टू हेल्थ है, तो पाकिस्तान में तो वो राइट ही नहीं है। सो ये नीचे ही हम बातें करते रहते हैं, ऊपर तक तो जाते नहीं, ना हम सुप्रीम कोर्ट में एज ए पब्लिक इंटरेस्ट लिटिगेशन कर सकते हैं, ना हाई कोर्ट में कर सकते हैं। सो
नहीं, ये परसेप्शन है आपकी। नहीं, दिस इज परसेप्शन कि राइट नहीं है। माइक मेरा आपका ऑफ कर देगा जी। ये परसेप्शन है जी कि ये कोई ह्यूमन राइट नहीं है हेल्थ का, ये बिल्कुल झूठ है। हमारा जो फंडामेंटल एक्ट है उसके अंदर वेल बीइंग का जो है ना वो लिखा हुआ है, बेसिक ह्यूमन राइट है कि वेल बीइंग का ख्याल हुकूमत करेगी, और हेल्थ की डेफिनेशन ही फिजिकल, मेंटल एंड सोशल वेल बीइंग है। सो आप अगर किसी लाल बत्ती के पीछे लगाना चाहते हैं और ह्यूमन राइट के तौर पे इसको लगाना चाहते हैं, लेजिस्लेशन करना चाहते हैं, तो वो एक और तरमीम करनी पड़ेगी आईनी। आई थिंक विद इन द करंटली फंडामेंटल्स ऑफ जो पॉलिसी है हमारी, उसमें 38 रूल है, उसके अंदर आप बड़े आराम से वेल बीइंग को आप कोट कर सकते हैं, ये कर सकते हैं, क्लास एक्शन सूट हो सकता है, ऐसी कोई बात नहीं है। इट इज ये हमें जरूरत नहीं है कि उसको हम राइट्स में लेके जाएं, वेल बीइंग का राइट हुकूमत के पास है, आप उसको इनडायरेक्टली एजुकेशन हेल्थ उसमें आ जाती है।
जी, अस्सलाम वालेकुम जी, I am Ambar Faruqi from Roche, Pakistan. It's a Swiss pharmaceutical company. I am a head of access and policy and regulatory. So first of all, I would like to just give a comment that what's the difference between local pharmaceutical and multinational companies, that we do have two types of oversights on us, like it's one local law, like DRAP law, and other than that, because we are representing global companies, so all global laws also implement on us. So since 2019, we are following IFPMA guideline where all type of giveaways, medical utilities and all things were banned to give to doctors, and we were abiding this. Then it came in 2021 draft guidelines where again ethical marketing rules, where it was again emphasized that there would be no giveaways to doctors, and also the medical conferences would be only for doctors, not for their spouses.
Madam, if you can have a question.
So the question is that when 2021 there was SRO, and it took 3 years for the implementation of that SRO. Dr. Baidullah is here, he was the director of pharmacy services at that time. He put maximum efforts to implement that SRO. So, but there were so many hindrances and challenges. So if for the implementation of one SRO it took 3 years, that how we can now think that just of arranging these forums, all pharmaceutical companies, and one fine day they will submit their...
You want to respond?
Marketing.
I think, but this is the whole point. This is what I was saying, is that we need these dialogues. You can't have 700 companies on one page unless you all are willing to talk to each other. And today we have the PPMA here representing over 250 companies, and the Pharma Bureau representing 18 companies, but our market share is reasonably large. So, these are the things that we need to have, these dialogues. If we don't have them, we won't get the other 300 and something, 400 companies to come in as well. And as we've been saying, DRAP has to strengthen its capacity more than anything else so that it can deal with this problem. Because unless they have the capacity to regulate, there's going to be no change. So I think, and I'd like to give credit to them that they are making huge efforts to do things. They've digitalized a lot. A lot of things have happened, which I've been watching now for so many years. And in the last year or so, there's been a sea change.
Yeah, I think we have two comments on this side. Yes, madam, please, and then Sardar Shabir sir.
मैडम आयशा से क्वेश्चन है, आपने पहले जब बात की थी तो आपने जो इंटरनेशनल फार्मास्यूटिकल है उसके हवाले से बात की थी. उनका सबसे बड़ा प्रॉब्लम, आई अंडरस्टैंड एविडेंस बेस्ड होता है, लेकिन कॉस्ट का है. अभी रिसेंटली एक फार्मास्यूटिकल आई हुई थी, वो अपनी एक वैक्सीन जो कि 45,000 की एक है, उसके 2 डोजेस लगने हैं और वो 50+ की पॉपुलेशन को देना चाह रही है. एंड देन वन ऑफ द कन्विंसिंग पॉइंट्स शी said to me was, लोग दुबई जाते हैं ये वैक्सीन लगवाने, people who can fly out to Dubai can afford it, but what about the population which is not affording? So cost के ऊपर आप लोग क्या कहना चाहेंगे?
I think, as I said earlier, it's not the duty of the pharmaceutical company to vaccinate everyone. That's the government. And if you don't allocate money to health, which we don't do in Pakistan, if you don't allocate money to health, I mean, you can shake your head or as much as you like, but the fact is that these are corporations. They have shareholders. They will provide you this medicine. I mean, this vaccine, I know which one you're talking about. This vaccine is actually being priced at the lowest price in the world in Pakistan. Now, I don't know how much better one can get. Pakistan, by the way, for everyone here, just for your interest, general interest, we have the lowest medicine prices in the world.
Yeah. Sardar Shabir sir. Yeah.
Ji, thank you so much. I'm Sardar Shabir Ahmed, basically a student of Pharmacy, Law and Public Health, and serving as Secretary Quality Control Board Islamabad and Vice President Pharmacy Council of Pakistan. My question is directed towards Dr. Nur Mohammad Shah Sahab. You have referred to as the shortage of human resource as the biggest challenge the DRAP is facing right now. The provisions of the DRAP Act 2012 clearly says that this will be an authority with the status of a body corporate and with full functional and financial autonomy. So despite having this legal status and having this sort of autonomy, why are you facing human resource and other challenges?
Thank you. Challenges तो होते हैं, अगरचे ठीक है autonomous body है, हमने advertisement की और प्रोसेस शुरू किया ह्यूमन रिसोर्स का, लेकिन उस पे जो है कोर्ट्स के स्टे आ गए, तो उस वजह से जो है वो प्रोसेस हमारा कंप्लीट ना हो सका और हम ह्यूमन रिसोर्स जो है हायर ना कर सके. हमने फर्दर जो है वो की है, उसके बाद ठीक है वो प्रोसेस रुक तो गया है, कोशिश भी कर रहे हैं ठीक ठाक, और फर्दर भी हमने वो जो है कि वो पोस्टों के अलावा और भी हमें ज़रूरत है, लेकिन प्रॉब्लम होती है. आपको बता दिया कि कोर्ट की तरफ से स्टे है और भी इस तरह के कंस्ट्रेंट्स है.
Three questions, Dr. Mushtaq, and then Wakar Bhatti Sahab, and then we come here. जी डॉक्टर साहब.
मेरा तो सॉर्ट ऑफ कमेंट है प्रोफेसर शहजाद साहब के उस पे के सवाल नहीं है, अगर उसकी इजाज़त हो तो, रिगार्डिंग पब्लिक प्राइवेट पार्टनरशिप, डेवोल्यूशन और ये सारी चीज़ें. But again, my class fellow Dr. Samin Siddiqui has been leading devolution process in 2002, और PLU आने के बाद जब वो आ रहा था तो ब्यूरोक्रेसी के अंदर इम्प्रेशन ये था, बल्कि उनकी कमिटमेंट ये थी कि DCO बनना था DC ने, तो उन्होंने कहा कि we will not let our colleagues become DC zero, और उन्होंने कोशिश की और within 4-5 years it was rolled back. उसके बाद पंजाब गवर्नमेंट में और बाकी सारी जगहों पे भी ऐसे ही होगा. जो लोकल गवर्नमेंट एक्ट्स हैं जिसके तहत डिस्ट्रिक्ट हेल्थ अथॉरिटीज बननी है, दैट एक्ट इज देयर फ्रॉम 2016 ऑनवर्ड्स. डिस्ट्रिक्ट हेल्थ अथॉरिटीज नहीं बन पा रही, और वन पर्सन हु इज DC ऑफ द डिस्ट्रिक्ट, ही इज हेडिंग दैट डिस्ट्रिक्ट हेल्थ अथॉरिटी। तो डेफिनेटली ये सारी चीजें करने के लिए यू नीड टू हैव पॉलिटिकल विल एंड स्ट्रेंथ ऑल्सो। बट अगर ये ब्यूरोक्रेट्स और इनके हाथों में पॉलिटिशियन भी खेलेंगे तो वी विल नॉट एंड एनीवेयर। दूसरी बात सिर्फ ये थी कि प्राइवेट सेक्टर को, जैसे भी आप कहें कि सुबह को पब्लिक है शाम को प्राइवेट है, प्राइवेट सेक्टर को हम आइसोलेट नहीं कर सकते। ये बेसिकली मेरा कमेंट।
सो विल टेक टू मोर क्वेश्चंस। वकार साहब जी, अगर सवाल है तो वरना कमेंट हम लंच ब्रेक में लें। सवाल है तो आप प्लीज गो अहेड।
सर कमेंट करना है मुझे और उसके साथ एक सवाल करना है, क्योंकि
पहले सवाल कर लें, कमेंट विल डू इट इन द लंच ब्रेक।
चले बाहर रहने दें फिर।
चले चले करें, कमेंट करें आप तो।
थैंक यू वेरी मच। अच्छा, कमेंट का मसला पता है कि मैं बंदा गुस्ताख हूँ ज़रा, अगर किसी को मेरी बात बुरी लगे। मैडम आयशा ने कहा कि एमएनसीज जो हैं वो चली गई हैं और 2 सेट मैन्युफैक्चर कर रही हैं। क्यों कर रही है? क्योंकि वो उस जो हरकतें हमारी लोकल कंपनीज कर सकती हैं ना, वो नहीं कर सकती, तो वो भागेंगी। वो क्या करेंगी? जाहिर सी बात है उस तरह वो compete नहीं कर सकती। लेकिन अभी परसों एक तस्वीर जारी की है कि एमएनसी ने कि वो ड्रैप के एक डायरेक्टर साहब को भी लेके गई हैं और कुछ डॉक्टरों को भी लेके गई हैं डेनमार्क में। तो यहाँ की एमएनसीज भी वही हरकतें कर रही हैं जो कि मजबूर हो गई हैं उस पर करने पे। इन्होंने ज़ैनब ने कहा कि इनके पास कंप्लेंट्स आती हैं, ये मुझे बहुत अच्छा लगा सुन के कि इस तरह, लेकिन कंप्लेंट्स नहीं आ रही हैं, लोगों को पता नहीं है। IHRA इस्लामाबाद की जो हेल्थ रेगुलेटरी अथॉरिटी है वो फतह कर ली गई है। एक प्राइवेट अस्पताल के मालिक जो हैं वो उसके बोर्ड के चेयरमैन बन गए। तो अब बंदा कहाँ जाए, किसके खिलाफ? IHRA में किसके खिलाफ जाएगा? मैं बात मेडिकल एजुकेशन की साथ चले गए।
वकार साहब सवाल, अगर वी आर रनिंग वेरी लो ऑन टाइम, प्लीज
चलें बस।
ठीक है जी, I'll come to you। जी डॉक्टर साहब प्लीज गो अहेड। We'll just take last comment on this.
This is a comment. Industry support to an expert to attend an international conference and present their scientific work and gain experience and share experience also. It's considered as joyride. This is a completely wrong perception. And I think we must distinguish between genuine visitors to these conferences and the genuine joyriders.
Thank you. Aisha, you want to respond?
I think the doctor just responded pretty much, because this particular instance that Mr. Vakar Bhatti is talking about is an educational visit, and it is to deal with a very serious problem in Pakistan, and it's being paid for by this company. They've taken people to educate them and not to promote a product.
Okay. No, thank you for all the comments. I think we have 5 minutes left, and I would like to have a quick reflection from each of the panelists. I think one common theme emerging from this discussion, अगर unethical practices systematic हैं, तो क्या ट्रांसपेरेंसी कैन कंट्रोल इट? एंड अगर तो सवाल ये भी है कि क्या हम इस कॉन्वर्सेशन के लिए एज इंडस्ट्री रेगुलेटर तैयार भी हैं कि जी ये जो डेटा डिस्क्लोजर की हम बात कर रहे हैं ऑन डिसिप्लिनरी एक्शंस ऑन अगेंस्ट डॉक्टर फार्मास्यूटिकल कंपनीज, कैन इट गो पब्लिक? एंड इफ इट कैन गो पब्लिक, व्हाट काइंड ऑफ रिफॉर्म्स विल स्टार्ट फ्रॉम यू?
हर सोसाइटी को ठीक करने के लिए, हर फील्ड को ठीक करने के लिए जो एक वज़ा की गई बात है वो ये है कि अमर बिल मारूफ व नही अनिल मुनकर, एजुकेशन देना और उसके साथ साथ फिर रेगुलेशन, नही अनिल मुनकर, बदी से रोकना। अब बदी से रोकने के लिए रेगुलेशंस है, तो हमें साइड बाय साइड जो है रेगुलेशंस बनानी भी चाहिए और इम्प्लीमेंटेशन भी करनी चाहिए। हमारे उसमें तो है ठीक है, हमारे सबका ये है, यानी रेगुलेटरी अथॉरिटी जो हमारी है, इसी तरह उनकी भी जिम्मेदारी है। स्टेक होल्डर्स अगर इंडस्ट्री है, साथ जो सर्विसेज वाले हैं, डील करने वाले PMDC है या हेल्थ रेगुलेटरी कमीशन है, तो इन हमारी सबकी जिम्मेदारी है। हम अपने पार्ट पे मैंने अब तो कह दिया कि है रेगुलेशन भी है ये कि उन्होंने डेटा भी देना है, लेकिन फिर भी हमारे पास उतनी ह्यूमन रिसोर्स नहीं है क्योंकि हमारा स्कोप बहुत बढ़ गया है। जो हमारा ड्रग एंड मेडिसिन का था, फिर नंबर ऑफ फार्मास्यूटिकल यूनिट्स जितने बढ़ गए हैं, उसके साथ साथ हेल्थ एंड OTC का फील्ड बहुत बड़ा है, ये सारे मिल के हमारे लिए कंस्ट्रेंट है। तो अगर ये हमारा हाल हो जाए तो रेगुलेशंस है भी हमारे, इवन 1976 के तहत जो रूल्स बने हैं उनमें भी है कि वो अपने जो इनकम है उसका एक प्रॉपर पोर्शन ही स्पेंड कर सकते हैं, और वो भी इथिकल मार्केटिंग, वो और फिर उन्होंने रिपोर्ट भी करनी है। लेकिन चूंकि वो ह्यूमन रिसोर्स की शॉर्टेज है, उस लिहाज से हम उस तरह नहीं जा सके।
थैंक यू डॉक्टर नूर। डॉक्टर ज़ैनब, इफ यू कैन।
थैंक यू काशिफ। पहले तो आपका क्वेश्चन कि कैन वी अबाउट डिस्क्लोजर एंड शेयरिंग, तो फर्स्ट वी हैव टू कम ऑन वन पेज ऑन व्हाट इज इट दैट वी वांट टू डिस्क्लोज, व्हाट इज द ऑब्जेक्टिव ऑफ दैट, which regulatory body will disclose what is going to be the purpose of it. खाली हमने सिर्फ किसी को कोई मजाक उड़ाने या किसी को डाउनग्रेड करने, किसी कंपनी को या किसी फिजिशियन को नहीं करना, हमने उसको करना है टू गेन समथिंग फ्रॉम इट, टू प्रमोट गुड वर्क. सो अनलेस वी आर ऑन वन पेज ऑन द सिमिलर फ्रेमवर्क, ऑन द गोल्स एंड ऑन द ऑब्जेक्टिव्स, this will not be a good exercise, because culturally the country, the citizens, they are not ready for it. I don't see it, because if I am going to tell that this particular doctor malpracticed and I make that disclosure, you can imagine the public, how the public is going to respond to it. We are not mature in that sense yet. So first, I think the regulatory bodies, we all sit together, we define a framework, define what needs to be disclosed, share among ourselves first, see where it is taking us. Is it actually building in a positive direction? And then it can come to the public disclosures. कुछ points थे काशिफ मेरे रह गए थे जो I want to cover here.
You will have
is
1 minute.
1 minute. Yes, I am going to cover it in 1 minute. कुछ चीज़ें ये है कि when we talk about the ethics curriculum, very well done, and I'm really looking forward to PMDC doing it. But we also need the CPSP to be present, to be doing the PG training. And ethics जो है वो पढ़ाई खाली नहीं जा सकती, कोर्स कर लिया और CME पूरी कर दी, it will not work. As a physician, ethics should be in the genome of every healthcare provider. And to do that, it will take more than that. It will take a lot of role modeling and a lot of reflective practice. And so I think wherever we produce such a CME program, I would request all the like CBAC to contribute in that way, so that physicians, or especially जो generation Z, जो पुराने हैं उनको ठीक करने में शायद थोड़ी मुश्किल हो, लेकिन जो already हमारी new generation है, they are the ones who can actually deliver in the next 1 decade on a better model. Then two things which I have, one thing is that
I'm sorry, I'll have to cut you.
Okay,
just
sure.
first. Thank you. Ms. Aisha, off you.
Sorry, what was your question again?
The question is, how do you encourage companies to disclose, data on the ethical compliances and also on the regulator level?
Well, I think first of all you need a transparent reporting mechanism, and you need a central database, and that requires DRAP now to go after those 700 companies and make sure that all of them are on the database and all of them are reporting. So it's really DRAP that has to do it. And the real issue is that of the 700 companies, if you look at the market share, 98% of the market share is with less than 100 companies. So 2% is what you are not able to regulate, pretty much. So I think this is a bit of a problem, and it needs to be looked at and addressed. And the only way we are going to deliver quality in this country is if we agree that price is not the consideration. You cannot produce medicine if you're not willing to put in the ingredients, and they cost a lot. I mean, people are willing to buy chalia in packets for 15 rupees or 10 rupees, but they're not willing to buy a tablet for 2 rupees or 3 rupees. So I think we need to get our priorities right as well on that.
Yeah. Thank you. Very important point on price versus quality and what should be regulated here. Dr. Shehzad, last comment from your side on.
थैंक यू। जब आप गवर्नेंस की बात करें ना तो 100 साल पहले अल्लामा इकबाल शायर मशरिक ने कह दिया था गवर्नेंस का तरीका। उन्होंने कहा था ऋषि के फाकों से टूटा ना ब्राह्मण का तिलिस्म, ऋषि के फाकों से टूटा ना ब्राह्मण का तिलिस्म, असा ना हो, असा मतलब डंडा, असा ना हो तो कलीमी है कारे बेबुनियाद। डंडा ना होता तो अल्लाह से कलाम करना भी उस लेवल का नहीं था, वो बेबुनियाद था। इसका मतलब ये है सर कि जो आपकी असल चीज़ है वो डंडा है और उसका मतलब यहाँ पे इन्फोर्समेंट है। हम ओवर लेजिस्लेटेड कंट्री हैं। मैंने डॉक्टर संजय निस्तर ने को आज 10 साल पहले रिव्यू किया कि हमें क्या जरूरत है लॉज की। पाकिस्तान इज ओवर लेजिस्लेटेड कंट्री इन द वर्ल्ड इन एनी सेक्टर, नंबर 1। नंबर 2, हम ओवरली पॉलिटिकल हैं। आप कहते हैं ना पॉलिटिकल विल, डिफरेंशिएट बिटवीन व्हाट इज पॉलिटिकल विल एंड व्हाट इज पॉलिटिकल इंटरफेरेंस। पॉलिटिकल इंटरफेरेंस इज नॉट पॉलिटिकल विल। तो जो गवर्नेंस है इसमें डंडा जो है, जब तक वो ऊपर वाले जो कि जिन लोगों के हाथ में इख्तियार है उन पे नहीं फेरेंगे ना, डंडा जाता है गरीब पे, डंडा जाता है सबसे कमजोर एम्प्लॉई पे। सस्पेंड कौन होता है, टर्मिनेट कौन होता है, लोएस्ट रैंक का ऑफिसर। सो हमारा अगर अपने करप्शन को और ट्रांसपेरेंसी को, अकाउंटेबिलिटी को, गवर्नेंस को इंप्रूव करना है तो दोज हु मैटर, दोज हुज डिसीजंस मैटर, दोज हु आर द पावर होल्डर्स, उनको बनाएं, उनको पकड़ें, उनको मिसाल बनाएं। ये एमओ, नर्सों को, डॉक्टरों को सस्पेंड करने से या फार्मास्यूटिकल कंपनी के रेप्स को करने से कुछ नहीं होने वाला हाई लेवल के ऊपर। और ये होगा तीन वर्ड्स हैं सर, अकाउंटेबिलिटी, ट्रांसपेरेंसी और तीसरा वर्ड हम हमेशा भूल जाते हैं, पार्टिसिपेशन। अकाउंटेबिलिटी और ट्रांसपेरेंसी के लिए पार्टिसिपेशन रिक्वायर्ड है। इस तरह हम सारे आज एक टेबल पे बैठे हुए हैं, तो आप उनके साथ ड्राइव को चाहिए कि वो फार्मा ब्यूरो के साथ और पीपीएमए के साथ रेगुलरली पार्टिसिपेट करके इस सवाल का जवाब निकाल ले। और मैं यहाँ पे ऑफर करूंगा, हम हेल्थ सर्विसेज एकेडमी इज होस्टिंग इज बेसिकली हैविंग द नेशनल हेल्थ पॉलिसी थिंक टैंक। तो अगर ट्रांसपेरेंसी इंटरनेशनल चाहे, आपकी लंदन स्कूल चाहे, तो हम फ्यूचर में इस डिस्कशन को, आई एम विलिंग टू टेक दिस फॉरवर्ड, आई विल बी वेरी happy to host this post-op sessions or anything. HSA is available for all of you. Thank you.
Thank you very much, Dr. Shehzad, and also I'm grateful to all the panelists for your insights, and also to the participants for the inputs that you have given. I think a lot of themes have emerged that can help us in sort of co-developing the policy recommendations that we have on enforcement and regulation. Just to reiterate what Dr. Shehzad said at TI and also Patients Not Profit, what we are also looking forward ahead is to do this conversation at provincial level, bringing different stakeholders on board. So thank you very much once again to all the panelists. Thank you.
Thank you everyone for this rich exchange. We have covered a wide spectrum today, from policy recommendations to practical reforms in professional standards, capacity building and regulatory frameworks. I will now invite Professor Michal to present a summary of the key discussion points, highlight agreed actions and identify areas for further deliberations.
We've had quite energetic discussions, thank you. I will summarize some of the key points, and I'll ask Kashi Saab and Dr. Smeen to add from their panels. So it's really clear that a multi-stakeholder forum like this is useful and needs to continue, and perhaps it should have formalized TORs, we've heard, with clear roles. बार-बार कहने के सबके roles define होने चाहिए. Trust deficit की बात हुई थी. Let's address that. Often it's when we don't talk that the lack of trust grows. So that can be a concrete action. Have further meetings, but also have it formalized in a way. Thank you so much to Dr. Shehzad for offering support. Ubaidullah Saab ne bhi kaha that RAP would be willing to come forward. So I can see that being a really important output. There are solutions in other countries that we can learn from. I know it's really difficult issues, but Pakistan is not the only country that faces this, so there is hope. That's number one. Number two, what I heard is it's great that positive steps are being taken. We heard about PMDC introducing mandatory CME potentially. They also mentioned that 300 cases of malpractice have been investigated. PPMA said they're willing to come forward and support. DRAP is also willing to support. So it's great. Those are positive steps. My question here is, what about the transparency and how can we monitor progress? Because we do want to build public confidence, and if positive things are being taken, please unko छुपाएं नहीं. अगर अच्छे काम हो रहे हैं, please उनको public domain में लाएं, हमारे journalists के साथ share करें, positive stories निकलें, लोगों का confidence बढ़ेगा, transparency बढ़ेगी, please. Number three, there were some clear areas of collaboration that I could see. One of them was on the continuing medical education. So what I would like to see is that the expertise that we already have and the work that's been done isn't wasted. CBEC ne kaam kiya, Dr. Rubina aap bhi keh rahi thi. There's work that's already been done. Pharma industry's done work. Let's use that और सब साथ आके एक बहुत अच्छा technically sound curriculum बनाए for undergraduate and continuing medical education that has ethics in the heart. We can be a leader in this from an LMIC context because we've done so much work on it already. But अकेले नहीं होगा. Let's come together on this, and I believe that there might be a way that the industry can also support with resources. Lots of red flags when industry gets involved. I know I talk about this all the time, but there might be a way that industry can help an independent group, a consortium such as CBEC, to really improve the educational material and share some of the burden of our regulators. And my fourth and last point that I'm summarizing from the discussion, potentially controversial, but जैसे Dr. Shehzad ने बोला, performance indicators of the highest level officials. Let's discuss this. What could those look like? What is the comfort level with that? And what will regulators be willing to report? Dr. Zainab ne baat ki about the culture issue. So yes, of course, maybe naming individual doctors, naming and shaming them isn't the right way to go. But is there an issue with saying, PMDC took this many actions, SHCC took this many actions? Can we do that to see the progress and to build public confidence? Or what are the barriers to doing this? And what sort of performance indicators should be there for the higher level officials? I think that could be quite a major step forward. So a few points for discussion, and I hope we can take them forward. Kashif, if there's anything you would like to add, or Dr. Samin, please do so.
I think No, thanks, Michal. I think you have very well covered all the key points. One point that I wanted to highlight was, I think, what we have seen from the discussion since morning is also that maybe the current governance structure that we have within the healthcare system is more of reactivity. What is needed is a more of a proactive approach. And there, I think, maybe for future, there are some of the stakeholders at this point that I picked from Ms. Aisha's remarks, that if for the listed companies, again, a lot of the recommendations that we are putting on the disclosure of data, whistleblowing, they essentially come under the regulators such as SCCP, State Bank and all. And there, for the listed companies, again, there are a lot of gaps because these disclosures are the voluntary compliance at the moment. They are not the mandatory compliance. So at the same time, how do we also show this value addition to the listed companies, that there is a value if they do the voluntary reporting on these ideas. So that was, I think, point that I wanted to highlight. But overall, I think what we have seen a key emphasis is making different interventions on ethical practices more proactive, and we'll see how all these interventions add into the developing this policy brief. Thank you.
I think you did a pretty good summary, but I think there's one point which I did mention, और मैं समझता हूँ उस पे emphasis की ज़रूरत है, और वो मैंने जो पहले भी कहा था कि how did it all start? Somebody did a research, and I think this whole thing is what I call evidence to policy. यही है ना, इन्होंने एविडेंस दी, उसको पब्लिश किया, उसके बाद पॉलिसी मेकर्स को बुलाया, एंड वी आर ट्राइंग टू सी हाउ वी कैन इन्फ्लुएंस पॉलिसी. So I think we should start believing in research. This is the power of research. This is the power of research that we are seeing here today. और एक study काफी नहीं है. We need to do more than one study, I can tell you that. And we need to do some interventional work. अब इन्होंने बताया कि जी इनका जो summary है वो ये है कि सिर्फ education से impact उस तरह नहीं आ सकता. यही है summary आपकी? That you've done it, but the education had a limited impact. Is that right or not?
Yes, and that the practices are much more rampant than we might.
So we have to do more and come up with an intervention package. जिसमें education भी हो, regulation भी हो, information भी हो, and so on and so forth, which we need to find out. So I think we need to give some importance, and I would like this to come out as a recommend, that we need more research in this country from, and I know that there is a R&D fund with DRAP. Am I right or not? I mean, this is exactly the purpose of the R&D fund, if I'm right. कि आप फर्दर उसको आप competitive तरीके से outsource करें, have more research, and then come up with a package which will have a set of interventions. ये कोई एक साल में नहीं होगा, ये 2 साल में नहीं होगा, but if we do it well, maybe within the next 3 to 4 years we can start making a difference. But we need to do interventional work. सिर्फ analysis से और mapping से, और we need to do interventional work. And so I would very much like to emphasize that we now need to go to the next stage where we do these kind of interventional works. But using not funds from UK, but funds from within Pakistan to do this work. So I just want to add that point.
Thank you. Akash, should I?
So I think Nina has done a very good job, and we still have 10 more minutes as per the agenda. So if there are any more comments or reflections, we have 10 minutes for the open forum. Ji sir, and then we'll go there.
Thank you very much for finally giving the opportunity, and we really appreciate Transparency International for creating this opportunity of dialogue between the policymakers and the technical people involved. My comment is that we have, like Dr. Shahzad has rightly mentioned, that in Pakistan there is no dearth of legislation. There are a lot of laws in Pakistan in general and for medical regulation. Issue is implementation. Issue is compliance. And but when we have the regulatory authorities in place, we have DRAP in place. It's a very good step in Pakistan. Go back to 2-3 decades, there was no regulatory system like DRAP is currently having. PMDC is very proactive now. Compare this PMDC with the PMDC which we had in our time, Dr. Shahzad. So it's very proactive. So there are regulatory authorities in place, but there is need to actually, like you said, Dr. Kashif, that they need to be proactive rather than just to wait for something to happen and then give the advice, rather than wait for some media report and then step ahead. They need to be proactive. They need to actually continuously educate the public for regulatory norms and rules and these things. And the last thing which I want to comment, that both our regulatory authorities, for example, DRAP as well as the PMDC, there is needed integration between the two authorities, coordination between the two authorities. I'll just give one example, that there is a phenomena, irrational prescriptions. So irrational prescribing practices, the role of PMDC is also there and the role of DRAP is also there.
Okay. Thank you, Dr. Muzaffer.
Thank you.
Thank you very much, Kashif and Transparency International for arranging this dialogue. मैं complete उन details में नहीं जाऊँगा जो discuss हो चुके हैं. The one point which we discussed 3 times, that is the utilization of Central Research Fund. I admit that this fund was non-functional 6 months before, but during last 1 year, DRAP has done कि उसकी जो utilization है 1978 rules की, we have done complete revamping. अनफॉर्चुनेट बात यह है, बल्कि एक अच्छी बात इस ऐसे फोरम्स का ये होता है कि जो बात मैं ऑफिशियल मीटिंग्स में नहीं कर सकता, यहां पे कर सकता हूं. और मैं बड़े क्लैरिटी से ये कह रहा हूं, और उन तमाम लोगों को जो सेंट्रल रिसर्च फंड का टाइम एंड अगेन जिक्र कर रहे हैं, उनसे मैं गिलामंद हूं कि 6 6 माह से हमने 2 दफा अखबार में ऐड दिया. We put on our website. We wrote letters to Higher Education Commission. We discussed in the official meeting, please come up with proposal. आपने antimicrobial resistance की बात की, आपने prescription की बात की. After revision of our research rules, previously, देखिए सरकार का जो काम होता है ना वो बाउंड्री में रह के करने का होता है. Previously ये फंड क्यों यूटिलाइज नहीं हो सका? Because उसमें लिखा हुआ था कि ये सिर्फ बेसिक और ऑपरेशनल रिसर्च के लिए है. पाकिस्तान के सिनेरियो में मैं नहीं समझता कि पाकिस्तान आने वाले 10 साल में भी कोई नई ड्रग डेवलप कर पाएगा. It draws billions and billions of dollars. बट हम क्या कर सकते हैं कि हम अपने डोमेस्टिक प्रॉब्लम्स को एड्रेस कर सकते हैं थ्रू लोकल रिसोर्सेज. डॉक्टर समीर ने कहा हमें इस काम करने के लिए यूके से फंडिंग नहीं चाहिए. हम भी यही बात कर रहे हैं. हमने अपने रूल्स को कस्टमाइज किया है इस वक्त, जिसमें एंटी माइक्रोबियल रेजिस्टेंस भी शामिल है, जिसमें प्रिस्क्रिप्शन ट्रेंड्स भी शामिल हैं, जिसमें एडवर्स ड्रग रिएक्शन रिपोर्टिंग भी शामिल है, जिसमें ऑनलाइन डेटाबेसेस भी शामिल हैं. प्लीज कम अप विद प्रपोजल. इंपॉर्टेंट थिंग इज कि अगर हम कोई एक कंक्रीट प्रपोजल नहीं लाएंगे उस वक्त तक ये नहीं हो सकेगा. एक बात. सेकंड जो बात मैं इसमें करना चाह रहा हूं, हमने इस फंड को ड्रैप के एम्बेड की एलोकेशन से बाहर कर दिया है. व्हाट वी हैव डन कि तमाम प्रोविंशियल गवर्नमेंट्स एंड आईसीटी इज एट द बोर्ड. ड्रैप इज नॉट एट द बोर्ड फॉर द एलोकेशन. प्रोविंशियल गवर्नमेंट से हमने नॉमिनेशन ली एंड नाउ दिस बोर्ड इज फंक्शनिंग, जिसने एलोकेशन करनी है. डिस्पाइट ऑफ ऑल ऑफ आवर एफर्ट्स वी रिसीव्ड ओनली 8 प्रपोजल्स across the country during last 6 months. और वो प्रपोजल भी वो प्रपोजल्स हैं कि हमने कोई केमिकल रिएक्शन करके एक दवाई बनानी है, हमने कुछ प्लांट से एक्सट्रैक्ट करके उसका एक्शन देखना है. So again my submission is कि go and see our website, rules are there, proposals are there, and it is not time bound. We are open to allocate these funds because it's not draft fund, it is an industry fund. Thank you.
Move to closing.
No, should we take one more question?
Very good question. Industry is entitled for this fund provided that कि वो रिसर्च करें जिसकी जरूरत है. Product development is not a research. If they want to do research, we are open to do that, and उसमें allocation करेंगे. ये नहीं है कि 100% allocation लेंगे. अगर एक कंपनी 100,000 1 लाख रुपए रिसर्च फंड में दे रहा है तो उसमें एक सर्टन परसेंटेज उसको दे सकता है. बट इंपॉर्टेंट थिंग इज उस बाउंड्री में आपको आना है. आप उस बाउंड्री में रहते हुए आप आए. आप हॉस्पिटल हमें कोई एलोकेशन की रिक्वेस्ट दे, बट डेफिनेटली हम तो माइल बाय करम है, कोई साइल ही नहीं. थैंक यू.
Thank you. One last comment, but I think एक area of collaboration हो सकता है to put together proposals. We're all here.
Thank you. I just want to talk about something no one talks about. In the recent past, the culture of witch hunting and misuse of accountability has become very well entrenched in our public systems. And this prevents timely decision making or even any decision making on the part of leadership, not just the top leadership, but middle level and lower level leadership. And the net result is that in the end, nothing gets done.
Thank you. And just as I'm passing the mic, I would say one implementation की बात हुई थी ना. I would just like to put this thought in the idea. This started with research. Imagine if we did some research looking at private diagnostic laboratories and sending lab representatives to doctors. हमें क्या पता चलेगा? Or if we do more research like this, if we go to medical colleges around the country and see how they're actually functioning by sending a fake student to apply, how many medical colleges will really be functioning? It's not the role of researchers really to be doing this fully, but imagine if we started doing this, हमें क्या पता चलेगा before we, let's admit these issues and address them, as well as saying that systems are in place. So that's one way that we can push for implementation, but we shouldn't need so much evidence when we all agree that these issues exist.
I just want to share one small thing. I mean, at the system level, especially for health system, there is a missing piece for quality assurance, and prescription audit is part of the quality assurance. So there is a missing element of quality assurance framework and structure in place in the system. So that is very important, and it actually, address all the issues related to prescription and rational use of medicine, etc.
Okay. Last comment.
थैंक यू वेरी मच। आज बड़ा एंजॉय किया, बड़े सीनियर्स लोग बैठे हैं, बड़ी रूल रेगुलेशन की बातें सुनी और मसलसल सुनते आ रहे हैं। मैं एक छोटी सी ऑब्जर्वेशन देनी चाहूँगा और मैसेज भी ट्रांसपेरेंसी की तरफ से भी और तमाम लोगों के लिए भी, कि रूल्स बहुत इम्पॉर्टेंट होते हैं क्योंकि वो आपको रास्ता देते हैं, लेकिन सबसे इम्पॉर्टेंट बात जो है रूल्स की इम्प्लीमेंटेशन। आप 2000 रूल्स बना लें, अगर वो इम्प्लीमेंट नहीं होने तो सब बेकार हैं। आज भी अगर हम उठा के देखें, एक सीनियर हमारे कह रहे थे पाकिस्तान में बहुत ज़्यादा एक्ट हैं, तो एक दफ़ा मैंने रिसर्च की, पाकिस्तान में 197 एक्ट हैं, जो आज तक किसी को पता भी नहीं होगा कि 197 एक्ट क्या करते हैं। कुरान भी जब आया था 2000 साल पहले, तो कुरान भी में ये लिखा हुआ है, या कुरान भी ये है कि इसको खाली पढ़े नहीं, इस पर अमल करें। तो एक रास्ता दे दिया हमें इस्लाम ने भी। आज भी हमारी यही बात है कि रूल्स ड्रैप के भी बड़े अच्छे हैं, पीएमडीसी के बड़े अच्छे हैं, हेल्थ केयर कमीशन के भी अच्छे हैं, लेकिन अगर वो 80% भी इम्प्लीमेंट हो जाएं तो हमारे बहुत सारे मसाइल का हल हो सकता है जी। थैंक यू वेरी मच।
Thank you all for engaging so meaningfully and helping us shape a collection of way forward. So to conclude the high-level forum, I am pleased to invite Mr. Mahesh Kumar Malani, Chairman of the National Assembly Standing Committee on National Health Services, Regulations and Coordination. He plays a key role in shaping national legislations and parliamentary oversight in the health sector. Mr. Malani will now deliver the closing remarks.
थैंक यू डिस्टिंग्विश्ड गेस्ट। पहले तो मैं काशिफ साहब का मशकूर हूँ जो इस हाई फॉर्म में मुझे मदऊ किया है। काशिफ साहब से मेरी 4-5 रोज़ से मैसेजिंग, और उसने मुझे कहा था कि आप क्लोजिंग रिमार्क और इंग्लिश में हमने कोऑर्डिनेट किया था, लेकिन मैं समझता हूँ कि मेरे जहन में यहाँ आने के बाद मैं जो इंग्लिश का मेरे पास ड्राफ्ट है वो नहीं यूज़ करता। सब यहाँ मेरे ख्याल में उर्दू समझते होंगे, तो मेरे जहन में कुछ चीज़ें आई हैं, तो मैं क्लोजिंग के साथ साथ कुछ मेरा एक्सपीरियंस भी शेयर करना चाहता हूँ। सबसे पहले तो मैं जो यहाँ हेल्थ से ताल्लुक़ रखते हैं उनसे मिलके बहुत खुशी हुई है। मेरा भी हेल्थ से ताल्लुक़ है क्योंकि मैं डॉक्टर हूँ। मैं पहले रजिस्ट्रार पीट्स में रह चुका था, फिर पॉलिटिक्स में आया हूँ और स्टेट मिनिस्टर भी थोड़ा वक्त रहा था, और अभी कमेटी में हूँ, स्टैंडिंग कमेटी का चेयरमैन हूँ। और आज मुझे बहुत खुशी होती अगर मिनिस्ट्री यहाँ होती। आज यहाँ मिनिस्ट्री का होना बहुत ज़रूरी था क्योंकि यहाँ काफ़ी सजेशंस मिलते और मिनिस्ट्री को इम्प्लीमेंटेशन में आसानी होती। आज मेरे ख्याल में बात इम्प्लीमेंटेशन की आई है, उसमें जो भी हेल्थ से ताल्लुक़ रखने वाले यहाँ बैठे हुए हैं उन्होंने दिल की बात नहीं की है, उन्होंने फॉर्मली बात की है। अगर दिल की बात करते तो काफ़ी हर डिपार्टमेंट में काम करने की ज़रूरत है। मैंने ज़्यादा में ज़्यादा हमारी जो असेंबली है उसमें हेल्थ में मीटिंग्स की हैं, तकरीबन 29 मीटिंग्स की हैं, तो उसमें हम पूरे डिपार्टमेंट की ब्रीफिंग नहीं ले सके हैं। इस वजह से क्योंकि हमने 4-5 डिपार्टमेंट लिए थे तो उसमें ही फंसे हुए हैं। यहाँ IHR से हमारे प्रिंसिपल साहब हैं, उन्होंने पॉलिटिशियन पे भी बात की, तो सब पॉलिटिशियन एक जैसे नहीं होते हैं, सब ब्यूरोक्रेट एक जैसे नहीं होते हैं। वहाँ हमारी स्टैंडिंग कमेटी में तकरीबन 2/3 डॉक्टर्स हैं, जो खास करके पोस्ट ग्रेजुएट किए हुए हैं डॉक्टर्स, जो MNA हैं। हम चाहते हैं, स्टैंडिंग कमेटी का वही रोल है जो ट्रांसपेरेंसी का रोल है, और मैं बिल्कुल दाद देता हूँ ट्रांसपेरेंसी इंटरनेशनल को, जिसने ये सेमिनार किया है। उनको जितना मालूम होगा शायद और किसी को हेल्थ के हवाले से मालूम हो। मैं कुछ डिपार्टमेंट के हवाले से बात करता हूँ। थोड़ा सा काशिफ जो है वो अलार्म दे रहा है कि वो टाइम थोड़ा लें, जो मुझे ड्राफ्ट दिया था वो थोड़े टाइम के हवाले से लिया था, लेकिन मैं अगर पूरा बात करूं तो काफ़ी टाइम लगेगा, लेकिन मैं उसको प्रिसाइज करूंगा। हमने सिर्फ 3-4 डिपार्टमेंट्स लिए थे, उसमें PMDC है, ड्रैप है, नर्सिंग काउंसिल है और IHR। तो नर्सिंग काउंसिल में तो हम हमारा पूरा टाइम जो है वो समझें तो आधे से ज़्यादा हमारा टाइम नर्सिंग काउंसिल में चला गया। मेरे ख्याल में सब यहाँ बैठे हुए हैं, सबको नर्सिंग काउंसिल का मालूम होगा। 1 साल से नर्सिंग काउंसिल का क्या असर था, और यहाँ तक कि वो ऑर्डिनेंस आना पड़ा, जो आपको मालूम होगा। ज़्यादा मैं इस पे बहस पे नहीं जाता, क्योंकि आप सब हेल्थ से ताल्लुक़ रखते हैं तो आपको पूरा अंदाज़ा होगा। क्योंकि नर्सिंग तो मेन इम्पॉर्टेंट है हमारा, वहाँ से नर्सेस निकलती हैं, बाहर जाती हैं, और पाकिस्तान में नर्सिंग का ही काम है हमारे हेल्थ केयर में। उस पर ज़्यादा मैं बात नहीं करना चाहता। ड्रैप हमारे से जल्दी निकल गई थी, क्योंकि ड्रैप के CEO जो हैं वो बैठे हुए हैं। इस पे हमने जल्दी, बाकी आपके साथ बैठने से हमें ये फ़ायदा है कि आपसे अगर मीटिंग्स होती तो आप काफ़ी हमें ऐसी पॉइंट्स इंटरनेशनल ट्रांसपेरेंसी के हवाले से देंगे तो हम उस पर काम कर सकते हैं। IHR की बात हुई तो उस पर पॉलिटिशियन पे भी बात की और ब्यूरोक्रेट पे बात की, लेकिन मैं इसके हवाले से ये कहूँगा कि IHR में अभी तक, बाकी डिपार्टमेंट में तो रूल रेगुलेशन एक्ट बने हुए हैं, लेकिन IHR में अभी तक कोई एक्ट ही नहीं है। और वहाँ तक हमें स्टैंडिंग कमेटी में सब कमेटी बनानी पड़ी। हमने IHR की सब कमेटी बनाई, उसकी रिजल्ट आई तो उसमें IHR के हवाले से हम बहुत मायूस हैं। उनके यहाँ कहा गया कि आप जो गवर्नमेंट की हेल्थ केयर जो है वो बंद होना चाहिए, ये बिल्कुल गलत है। मैं कभी भी फेवर में नहीं रहूँगा। मैं भी रूट लेवल से आया हुआ हूँ और रिमोट एरिया से आया हुआ हूँ। थरपारकर आपको मालूम है बहुत रिमोट एरिया है, और मैं रूट लेवल से 3-4 बार जनरल सीट पे वहाँ से आता हूँ, तो रूट लेवल का हमें मालूम है। हेल्थ के हवाले से मेरा प्रोफेशन है, तो वहाँ गवर्नमेंट के हवाले से भी फ्री ऑफ कास्ट वहाँ एंजियोग्राफी भी होती है, एंजियोप्लास्टी भी होती है, और पोनेस्टान कालपोल ये भी तो मिलती तो है ना वहाँ, तो लोगों को काफ़ी वहाँ फ़ायदा होता है। अगर प्राइवेट की बात करते हैं तो 2 कमरों में भी मेडिकल कॉलेजेस चल रहे हैं, और यहाँ बात हुई है कि मेडिकल कॉलेज सब एक जैसे नहीं हैं। आप लम्स DMC या यहाँ अलशफा है तो उसकी लेवल पे वहाँ से जो बच्चे निकलेंगे तो 2 कमरों से कैसे बच्चे निकलेंगे। तो IHR का काफ़ी काम है। वो IHR के हवाले से हमने सब कमेटी की रिपोर्ट भी दी है, उसमें सब डॉक्टर्स थे जो सब कमेटी में थे, लेकिन उस पर ज़्यादा मैं बात करना नहीं चाहता। लेकिन ये ज़रूर कहूँगा कि IHR को सही तरीके से इस्लामाबाद में काम करना चाहिए, और उसका बहुत बड़ा रोल है। ऑडिट का भी, जो हॉस्पिटल की ऑडिट करना चाहिए वो भी उनके पास एक्ट में नहीं है, वो नहीं कर सकते। तो उसके हवाले से अभी लास्ट मीटिंग थी, उसमें ये बात हुई थी कि आप कम से कम एक्ट तो बनाएं, एक्ट के बाद इम्प्लीमेंटेशन होगी। बाकी डिपार्टमेंट में एक्ट बने हुए हैं लेकिन इम्प्लीमेंटेशन नहीं है। नर्सिंग की बात हो गई, बाकी कुछ जिसमें काम करने की चीज़ है वो मैं आपको बताऊं कि मेल न्यूट्रिशन हमारे पाकिस्तान का बहुत बड़ा इशू है। मेल न्यूट्रिशन, न्यूनेटल डेथ्स जो हैं, उस हवाले से आपसे सजेशंस भी मिलना चाहिए, और उस पर काम करने की बहुत ज़रूरत है। और पीएमडीसी के हवाले से भी काफ़ी हमारी मीटिंग्स हुई है और मीटिंग्स चल रही हैं, उसमें भी काफ़ी चीज़ें हैं, जैसे मेडिकल कॉलेजेस उसमें आते हैं कि उसको कैसे 2 कमरों वालों को नहीं रजिस्टर करना चाहिए। और फॉरेन के भी आपको मालूम है कभी पीएमसी ने उनको अलाउ किया है, कभी नहीं किया, तो काफ़ी उसमें इश्यूज़ है, उनको इम्प्लीमेंटेशन सही तरीके से होना चाहिए। उसमें एमडीकेट के हवाले से भी कुछ चीज़ें वो भी हेल्थ में आते हैं, उसमें अच्छे डॉक्टर निकलना बहुत ज़रूरी है। तो एमडीकेट में भी काफ़ी लकुनाज हैं, तो उनको किस तरीके से हम सही करें वो भी आपसे हम सजेशन लेना चाहेंगे। और जब वहाँ हम बैठते हैं स्टैंडिंग कमेटी में तो मिनिस्ट्री कहती है कि ये सब ऑटोनॉमस है और ये वो कहते हैं कि मिनिस्ट्री, तो ये मिनिस्ट्री और ऑटोनॉमस का भी सिस्टम नहीं होना चाहिए। बीएमडीसी के ऑटोनॉमस है, आईएचआर वो ऑटोनॉमस है, नर्सिंग वो ऑटोनॉमस है, ये सब ऑटोनॉमस है। तो मिनिस्ट्री उसमें कोई मिनिस्टर कह भी चुका है, नर्सिंग के हवाले कह भी चुका है कि हमारा रोल वहाँ नहीं है। तो इनका कोऑर्डिनेशन होना बहुत ज़रूरी है। फॉरेन फंडेड जो भी यहाँ हमारे ईपीआई प्रोग्राम्स हैं वो भी अच्छी तरीके से चल भी रहे हैं, उनके हवाले से भी आपसे हमें सजेशंस चाहिए। मेरे ख्याल में स्टैंडिंग कमेटी का रोल और आपका रोल एक जैसा ही है। आप हमें अगर आप बताएंगे कि जो एक्ट है उसको सही तरीके से कैसे चलाया जाए और उनमें रिफॉर्म अगर करने हैं, तो मेरे ख्याल में आपका फोरम जिस तरीके से हमें सजेस्ट करेगा तो इससे ज़्यादा और फोरम हो ही नहीं सकता, क्योंकि आपका काम और स्टैंडिंग कमेटी का वही काम है, दोनों का सेम है। लेकिन हमें नॉलेज लेना आपसे ही वो नॉलेज मिलेगा। उस हवाले से मैं आपको गुजारिश करूंगा कि आप सब हेल्थ से ताल्लुक़ रखने वाले यहाँ बैठे हैं और आपको एक्ट के हवाले से कुछ रिफॉर्म के हवाले से भी आप हमें सजेशन दे सकते हैं। और ये फोरम बहुत अच्छा है, इस फोरम के हवाले से भी आप 1 बाय 1 कोई भी हमें रिटन में सजेशन देंगे तो हम ज़रूर फॉलो भी करेंगे और स्टैंडिंग कमेटी में वो ले आएंगे। अगर मैं काशिफ साहब को ये भी कहूँगा कि आप हमारी कमेटी के मेंबरान के साथ इनकी आप मीटिंग कराना चाहें तो हम मीटिंग कराने के लिए भी बिल्कुल हाजिर हैं, क्योंकि आपके जो हमें सजेशन मिलेंगे वो फ्रूटफुल होंगे और हम बाउंड करेंगे कि मिनिस्ट्री भी साथ हो और आपके सजेशंस मिनिस्ट्री और ये जो भी डिपार्टमेंट हैं, जो ऑटोनॉमस डिपार्टमेंट हैं, मिलके हमारे मुल्क में अगर हम हेल्थ को बेहतर करें तो मेरे ख्याल में सबका ये काम है कि हम पॉजिटिवली जाएं कि हेल्थ को कैसे मजबूत करें। तो इस हवाले से आखिर में मैं आपका मशकूर हूँ कि आपने हमें मदऊ किया और एक अच्छे फॉर्म के हवाले से सजेशन भी मिली हैं और आप रिफॉर्म के हवाले भी हमें कोई सजेशन देंगे तो हम बिल्कुल लेंगे। ड्रैप के हवाले से एक हमारे किसी कलीग ने कहा था कि ह्यूमन रिसोर्सेज, तो उसकी वाकई उन शॉर्टेज थी, लेकिन मीटिंग में ये बात आई थी और मीटिंग में जो ह्यूमन रिसोर्स का जो भी फुकदान है उसके हवाले से ड्रैप काम कर रही है। उसमें पब्लिक सर्विस कमीशन के मसले थे वो भी हल कर लिए, इन्होंने एडवर्टाइजमेंट किए हैं, जैसे ड्रग इंस्पेक्टर बहुत कम है वो ज़्यादा होना चाहिए, तो उस हवाले से ड्रैप काम कर रही है। हम उम्मीद रखते हैं कि ड्रैप जो है इस हवाले से काम और भी करेगी, ह्यूमन रिसोर्स को ये कंप्लीट करेंगे। उसके साथ कंपनीज या इंटरनेशनल कंपनीज भी हैं, लोकल कंपनीज भी हैं, इनसे हमें जो भी इनकी सजेशन मिलेगी मेरे ख्याल में वो ज़्यादा फ्रूटफुल होगी। मैं समझता हूँ मिनिस्ट्री से ज़्यादा आपका फॉर्म जो है वो बहुत इम्पोर्टेंट है। और ये यहाँ रिटायर्ड जज साहब भी बैठे हैं, ये आप सब जो हैं सब हेल्थ से मैं देख रहा हूँ कि हेल्थ के हवाले से बहुत आपको नॉलेज है, तो आप हमें बिल्कुल इनलाइट करें, हमें सजेशन दें और आपसे मीटिंग करने के लिए भी तैयार हैं और आपके सजेशन हम रिफॉर्म के तरीके से भी ले जाएंगे और मिनिस्ट्री को भी बाउंड करेंगे। जो पाकिस्तान में हेल्थ के हवाले से इम्प्लीमेंटेशन का जो फुकदान है उसको हम फुलफिल करेंगे तो हमारे मुल्क के लिए सेहत का काम अच्छी तरीके से जाएगा। और मैं इस्लामाबाद के हवाले से एक बात ये भी कहूँगा कि यहाँ हमारे जो बड़े हॉस्पिटल्स हैं, चाहे गवर्नमेंट के हो चाहे सरकारी हो, वहाँ ओवर क्राउड है। उसका रीज़न जो है वो यहाँ बीएचयू सिस्टम या आरएससी सिस्टम जो है वो इतना स्टेबल नहीं है, उनको स्टेबल करना चाहिए। क्योंकि वहाँ अगर देखें, इस्लामाबाद में भी 25 किलोमीटर अगर लेबर होना है तो वहाँ से हमारी जो खातून है वो यहाँ आना पड़ता है। कम से कम लेबर जो है वो बीएचयूज़ या आरएससी में 24 आवर्स होना चाहिए कि लेबर अगर वो हो जाए तो वहाँ हो जाए तो यहाँ लोड नहीं पड़ेगा। कम से कम इस्लामाबाद की हद तक ये होना बहुत ज़रूरी है। तो ये मेरे सजेशंस भी हैं और इस पर काम भी कर रहे हैं, लेकिन आपके सजेशंस जो है वो रिटर्न में भी अगर हमें आज के सेमिनार के हवाले से भी मिलेंगे तो आपसे वादा करते हैं कि हम स्टैंडिंग कमेटी में ज़रूर ले आएंगे। थैंक यू।
Thank you, Mr. Malani, for emphasizing the importance of collaboration and governance reform in building ethical, patient-centered health system. This concludes the formal proceedings of the high-level forum. Now, I would like to move towards the token of appreciation distribution. Thank you to all our speakers, moderators, and panelists for their valuable contribution today. To begin our token of appreciation, may I kindly invite Justice Zia Saab, Professor Mishal Khan, and Mr. Kashif Ali to please come on the stage to hand over the shields. We will start in sequence. First, Dr. Ubaidullah, please come and receive your shield. Please have round of applause. Dr. Mahesh, you are also requested to please come on the stage. Thank you, Ubaidullah Saab. So, moving toward the next panel. For panel 1, I would like to invite Dr. Zwan. Please come and receive your shield. Okay, Dr. Amir Jafri. Sir, please come and receive your shield. Mr. Zishan Nazir. Mr. Usman Wahid. Sir, please come and receive your shield. तालियां बजा दें प्लीज। And finally, their moderator, Professor Samin Siddiqui. Sir, please come and receive your shield. Thank you, panel 1. Now, panel 2. So I would like to have Dr. Noor Mohammad Shah. Please, sir. Dr. Zainab, Dr. Aisha. Dr. Zainab Hassan. Madam, please come and receive your shield. Miss Aisha. Dr. Shehzad. जी. Dr. Shehzad, I would like you to have your shield. So now I would like to call Mr. Mahesh. Yeah.
Ms. Aisha, come here.
जो खालिद महमूद ये वाले हैं इनको
कौन सर से पूछें खालिद का मुझे नहीं आता. Khalid Mahmood Saab, I would like to invite you to have your shield. So after this shield distribution, I would like to call everyone on the stage for group photo. I now invite everyone, please come forward for a group photo. Samin sir? Yes. Samin sir, photo के लिए. I think
देखते हैं हम कितने challenges solve कर सकते हैं. How long will it take us to arrange for the group photo? This will be the test of how much we